Good afternoon and welcome to this bill hearing for the House Health Committee. I'm Chair Bagnall here with my amazing Vice Chair Cullison and our team. I do ask for your patience if we encounter any technical or streaming issues. This hearing is being live streamed on the Maryland General Assembly YouTube channel. We do have a few virtual witnesses today, so please bear with us as we switch back and forth with the tech. Please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks as meetings can run quite long and hydration is essential. Please make sure to turn off your cell phones or turn them to silent at this time. If you see that a member is not present here, remember that they do have hearings in other committees as well as meetings, and they are staying informed on our proceedings. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist, and please keep your questions shorter than the answers. Today we're going to go in the following order: House Bill 1094, followed by 1375, 1565, 1380, 1435, 1251, 1107, 1461, 1117, and 1118. Of course, subject to the availability of our sponsors. And please keep in mind that sponsors are not time limited, but please keep it reasonable so that we don't have to revisit that rule, and all witnesses have 2 minutes. With that, we will turn to our first bill of the day. This is House Bill 1094. This is in health insurance graduate level clinical interns required reimbursement. Delegate Hutchinson, you're already there with your panel, so you can begin your testimony when you're ready.
Fantastic. We're trying to get through this Friday afternoon. So good afternoon, Madam Chair, Madam Vice Chair, members of the Health Committee. My name is Delegate Tom Hutchinson from District 37B on the beautiful Eastern Shore. I'm here to present House Bill 1094, Health Insurance Graduate Level Clinical Interns Required Reimbursement. This is a bill to address continuity of care, access to care, and address the healthcare workforce shortage issues. It was brought to my attention by my good friend here from the For All Seasons, which is a fabulous behavioral health and rape crisis center on the Eastern Shore. So during the interim, we actually worked together with the League of Life and Health Insurers to get their opinion to move forward with this bill without objection, and as you can see, they've not taken a position on this bill. Currently, Maryland has a regulatory barrier that actively hurts and disrupts care to patients. So in For All Seasons, for example, master's level interns are only allowed to bill for services that go through Medicaid. So this creates what's called a benefits cliff. So in this case, a intern is working with his or her therapist, maybe for months at a time. And then finally, they make some clinical breakthroughs, but maybe also during this period, they have a life-changing event and they now go to a commercial private insurance. And when that happens, they're forced to then switch their therapist. So House Bill 1094 fixes this by allowing private and commercial insurers to use a structured incident to billing model. So it'll allow the intern to provide services to the patient when they're covered under private insurance. The intern will work with direct supervision of a fully licensed professional, such as an LCSW/C. And the supervisor then signs off on every note, takes full clinical responsibility, and then bills under their NPI. So by supporting this bill, we're investing in the clinical readiness of our future professionals, which then ensures that no Marylanders are forced to abandon a successful course of treatment due to change in insurance coverage. It supports our students, our small practices, and most importantly, our patients. I'll conclude that I have been approached by many organizations that did want to amend on to this bill and to include other healthcare interns. I'm not accepting any of them. We have worked very closely with the League on this and taken their guidance on this. I've offered to them to come back. I'd be happy to work with them in the interim in conjunction with the League to bring potential legislation next year. So I respectfully ask for your favorable report on House Bill 1094, and I'll turn it over to Beth Ann Dorman, the CEO of For All Seasons.
Madam Chair, Vice Chair, and Committee, it's great to be with you. And I just want to echo what Delegate Hutchinson highlighted within this bill. As an outpatient behavioral health clinic, when we have master's level interns, it is an imperative component of our ability to serve the most clients possible. As an agency that serves over 4,000 clients a year, we have up to between 9 and 11 interns at a time, and if we are only able to send patients with Medicaid to those interns, it creates a hardship, as Delegate Hutchinson highlighted. The other thing that is an impact on our agency and why this becomes so important is that as an outpatient behavioral health clinic, we are a part of a system with the universities, whether it be the University of Maryland, whether it be universities throughout the state. We do not get any reimbursement to provide supervision and to have these interns as a part of our staff. And so it actually costs us money as an agency to bring in these interns, but we recognize how fiscally important it is for us long-term, because these are the folks that we are then hiring and keeping within our community to create full-time positions. And so this gives us the ability to cover some of those unbillable costs for our supervisors who are overseeing. And I think that's an important component of this bill. We are not saying that this is sort of a lackadaisical whoever wants to oversee these interns. We have a very structured program. We very much support that the LCSWC or the LCPC are overseeing and doing supervision with these interns. So we would not support this for a single entity who does not provide the supervision. This not only creates continuity of care for the clients, it also allows our agency to really reduce the administrative time that it takes to continue to redistribute clients. And when you're facing issues such as rape and sexual assault and some really difficult mental health issues, as our agency does, this will help make sure that our clients are coming first and not the administration of moving people around from place to place with insurance. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. For the record, Jeannie Hadaway-Riccio with For All Seasons. You have our written testimony and you've heard from our executive director, so I'll be brief today and just say that we believe that this legislation provides continuity of care, additional access to care, but it also provides important professional development opportunities for the workforce pipeline that we are trying to develop. And with that, we would respectfully request a favorable report from the committee.
Thank you for your testimony. Delegate Hutchinson, I also have a Lauren Weber. Are
She
you
was
here?
a backup just in case Ms.
Okay.
Gorman couldn't make it here today.
I thought that might be the case. I just want to double check. So I will open it up for questions from the members. Are there any questions for the sponsor or his panel? Seeing none, thank you very much
Thank you.
for
Thank
your
you.
testimony. We do have a favorable with amendment and then two more favorables. So let me go to the favorables and then we'll go to the favorable with amendment. So I've got Megan Goodman and virtually Jordan Anderson. And if you want to begin your testimony, Ms. Goodman.
Thank you. Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Megan Goodman, and I am an intern with the National Association of Social Workers, the Maryland chapter, also known as NASWMD. Thank you for the opportunity to testify today in support of House Bill 1094. NASW Maryland represents more than 2,600 social workers across Maryland, and we strongly support this legislation because it helps secure and strengthen the future of social work profession and the behavioral health workforce. Graduate-level clinical interns are an essential part of Maryland's behavioral health system. Students in social work, counseling, and psychology programs complete hundreds of hours of supervised field education in community clinics, hospitals, schools, and private practices. During this time, they are providing real services to real clients while being supervised by licensed professionals. However, many agencies are currently unable to bill insurance for services provided by these supervised interns. This creates a significant barrier for organizations that want to train students and expand services. House Bill 1094 addresses this issue by ensuring that insurance plans reimburse for services delivered by graduate-level clinical interns under supervision. Importantly, this bill does not pay interns directly. Instead, it allows agencies to recognize and bill for the care that supervised interns are already providing. This matters for the future of the profession. When agencies cannot bill for intern services, they may limit the number of placements they offer. This means fewer training opportunities for students and fewer providers entering Maryland's behavioral health workforce. By allowing for this reimbursement, this bill creates a more sustainable training pipeline for the next generation of clinicians. It helps agencies invest in supervision, expand placements, and integrate students into systems of care. For social work, field education is our signature in this profession. It is where students develop the clinical skills needed to support Maryland families and community. House Bill 1094 ensures that these training experiences are valued and supported within our healthcare system. For these reasons, NASW Maryland respectfully urges a favorable report on House Bill 1094. Thank you for your time and consideration.
Thank you for your testimony. And we're going to go to our virtual witness, and then I'll open it up for questions from the members. Jordan Anderson, if you can unmute and begin your testimony.
Hi, good afternoon, everyone, and Madam Chair. My name is Jordan Anderson. I am a social worker within higher education, and my primary responsibility is securing internship placements for graduate level social work students across the state of Maryland. In nearly every placement interview that I have conducted, students share with me their aspirations to work with individuals navigating one or more mental health diagnoses and want to provide treatment modalities to children, youth, and families to improve how they function as community members. And also in each and every one of my interviews, immediately after making placement recommendations and restating the requirements that were previously shared before me, that is placed from our accrediting body, the students explain that they cannot afford to stop working in order to obtain their educational goals. Our accredited body, again, mandates that students accrue a number of internship hours required for graduation, and those students must meet those requirements while continuing to support themselves and, in many cases, their families. And so that strain shows up with MSW students enduring financial instability, academic disruption, emotional exhaustion, for a degree that strengthens individuals in our Maryland communities. I share this not only as a social worker administrator, but from lived experience. While completing my second year social work internship at 24 hours a week at an outpatient mental health clinic housed within an elementary middle school in Baltimore, Maryland, I provided clinical services to insured clients without compensation or reimbursement under the supervision of an LCSWC. I was also working 2 part-time jobs and attending graduate school full-time. And so if this legislation was proposed and passed prior to 2018, this is something I personally could have benefited from my own self. And so unfortunately for years, the burden has simply been normalized for social work students to keep on attending placements without being paid while costs continue to rise, and that must change. And so by enabling reimbursement for House Bill 1094, this strengthens our Maryland growing behavioral health workforce, as well as modernizes how we train future social work students and clinicians. And so with that, I respectfully urge a favorable report for House Bill 1094. Thank you for your time and consideration.
Thank you for your testimony. Are there any questions from the members for this witness panel? Vice Chair Cullison.
Thank you, Madam Chair. I'm not sure what I'm missing here. Who's actually getting reimbursed? Is it the supervisor or the intern?
I'd have to double check. I'm pretty sure it is the intern. That would be.
For what I understand as well, of the bill that's being proposed is that the reimbursements would go to the agency that will be provided then to the student. So the students will get the reimbursement through the agency.
Through the agency. Okay. Thank you. That's good.
Thank you for the clarification. Are there any other questions for this panel? Seeing none, thank you very much for your testimony today. We do have one favorable with amendment, Megan Crosby Budinger. If you want to come up and begin your testimony when you're ready.
Good afternoon, Madam Chair Bagnall and members of the committee. My name is Megan Crosby Budinger. I'm a licensed clinical professional counselor, and I serve as the Program Director of Behavioral Health Integration in Pediatric Primary Care, or BHIP, at the University of Maryland School of Medicine. I'm here today in strong support of House Bill 1094. Maryland is facing a critical behavioral health workforce shortage. The state needs an estimated 30,000 additional behavioral health workers to meet demand, and our youth are already feeling the impact. In 2021, nearly 46% of Maryland adolescents with depression received no care. The gaps are even more pronounced in rural areas like the Eastern Shore and Western Maryland, where only 2 of Maryland's 24 counties currently have an adequate number of behavioral health providers. One way that BHIP works to address this crisis is through our co-located internship program, which places master's level counseling and social work trainees in pediatric primary care offices where they provide essential services, including mental health screenings, brief intervention, and referral coordination for youth in medically underserved communities. Our interns receive a rigorous curriculum and evidence-based interventions and are supervised by licensed psychologists, counselors, and social workers. Since 2012, BHIP interns have completed more than 13,000 behavioral health visits. Programs like ours help build the next generation of the behavioral health workforce. However, the longevity of models such as these are threatened by an over-reliance on fluctuating grant funding. House Bill 1094 would allow insurance reimbursement for services provided by graduate-level clinical interns under supervision. This would strengthen the workforce pipeline, expand access to evidence-based care for youth, and help sustain training programs serving Maryland's most vulnerable communities, providing greater access to high-quality care and ensuring that trainees are gaining access to evidence-based training. For these reasons, I urge the committee to vote favorably on House Bill 1094. Thank you.
Thank you for your testimony. Are there any questions for this witness from the members? I just had one question, because you were signed up as favorable with amendment, and I think I missed the amendment that you were suggesting, or?
So I noticed 2 things in the verbiage of the bill. The first was that the term direct supervision was used. Typically in healthcare, when we say direct supervision, it implies that the supervisor is in the room during the time of treatment. So for mental health trainees, we use more of an indirect supervision model or an oversight model in which the trainee sees the patient independently and then typically will meet with their supervisor once a week in order to review cases. The other thing I noticed is for LCPC students, they're actually able to be supervised by counselors, social workers, psychologists, or psychiatrists, and the verbiage of the bill just indicates LCPCs. So I would just recommend that it be amended to align with the regulations with the Board of Professional Counselors.
Thank you very much. Thank you for the clarification. Are there any further questions from the members? Seeing none, this concludes the bill hearing on House Bill 1094, and we're going to go to House Bill 1375. Delegate Howard, I believe you are your panel, and you are enough. So if you want to come to the table and begin your testimony.
That's correct, Madam Chair. I am the panel. Good afternoon, Chair Bagnall, Vice Chair Cullison, and honorable members of the Health Committee. For the record, my name is Delegate Seth Howard of District 30, and I am pleased to present HB 1375, Health Insurance, Lyme's Disease, and Related Tick-Borne Illnesses. The purpose of this cross-filed bill is to require insurers, nonprofit health service plans, and health maintenance organizations to provide certain coverage for the full length of long-term antibiotic treatment of Lyme disease and related tick-borne illnesses. This prohibits insurers, nonprofit health service organizations, and health maintenance organizations from placing a quantitative limit on or denying coverage for benefits required under this bill. To my colleagues on this committee who have suffered from this or know someone who has suffered with Lyme disease, wouldn't you like to have a treatment that would provide you relief? This bill, in consultation with a doctor and after a clinical diagnosis, allows you to make a decision on whether or not long-term antibiotic cure is right for you. I want to draw the committee's attention to page 2 of the unfavorable testimony from the Maryland Department of Health, and it states, in an effort to improve patient safety and mitigate poor outcomes, antimicrobial stewardship programs, otherwise known as ASPs, operating internationally, nationally, and locally, or evaluating and improving the way these antibiotics are both prescribed by clinicians and used by patients. ASPs ensure that antibiotics are used only when necessary and when appropriate, but then it turns around and says the department promulgates national ASP guidance regarding prescribing. appropriate antibiotics for the appropriate duration. This doesn't make sense. And it goes on to say, according to the most recent evidence-based guidance provided by Infectious Disease Society of America, American Academy of Neurology, and American College of Rheumatology, long-term antibiotic treatment of Lyme's disease and related illnesses runs counter to this evidence-based guidance. The fact of the matter is that each and every one of our physicians, our doctors, have access to all of this information and all of these studies. These are published works, and they would be using that guidance along with the guidance of the health department and these ASPs, and most importantly, your health information to develop a plan for long-term care using these antibiotics. Again, this is done in consultation with and after a clinical diagnosis of with your physician or a doctor. This is not just random, absolute access to this long-term treatment. I don't know what's getting lost, quite frankly, in the language of the bill in the department, but I will tell you, I've had this bill for many, many years. We are on a CDC hot list. We are growing constantly from people getting this disease in Maryland. And year after year after year, I think this is actually the same letter from the health department for the past 3 or 4 or 5 years. They just literally just changed the bill number. I've reached out to them. I've had, energetic phone calls, let's just say that, with them, trying to bring something to the table, trying to bring some flexibility to the table, and I really honestly received nothing. I would also like to point out that there is another opponent to this bill that did not provide me with their testimony. So I would love to see it so I could rebut it, but I was not provided that negative testimony. To stop pain and suffering, to stop financial hardship and devastation, I ask for a favorable vote. And I would like to call the committees. We put this together. It's in 14 by 8. It's in your packet. Talks a lot about and summarizes what's going on with Lyme's, where we are as far as clinical diagnosis and treatment, and where we are as far as not only regionally, but right here in Maryland.
Thank you very much for your testimony and for your continued advocacy. Is it before I open it up for questions from the members, is it the League of Life and Health Insurers of Maryland? You didn't have access to that?
I believe so.
Okay, we'll make sure we get you that information. Are there any questions for the sponsor on this bill from our members? Seeing none, I understand your frustration. Oh, Delegate Alston.
Sure.
I was trying to find the opposition so I could read it for him. I just wanted to give him an opportunity to reply since he hadn't seen it, but does anybody else have a question while I'm looking for it?
Yeah.
Oh, they oppose a mandate. So what would your response be to that?
On an opposed mandate?
Yes.
Again,
Mandated benefit. Under the Affordable Care Act, they are opposing a mandated benefit.
again, these people are being devastated. They're losing, some of these treatments are $100,000 within 2 years. There are people in this body that are suffering from this. I've had personal dealings with a constituent who, latest Facebook post as of last year, was homeless, living in a tent in the woods after being a successful career woman, married, losing everything, going on to couch surfing, going on to losing, again, everything, and posting about how she's going to make it through the winter because of her fellow homeless friends were teaching her how to be homeless in the winter, and reaching out, to my office about things that we could do to help her as well. I understand, they're opposed to the mandate, but I'm opposed to what's going on with thousands of people in Maryland and the financial destruction and the loss. And what I'm really opposed to, and what I'm offended by, is I understand their opposition to, but then they do nothing. They do nothing to they do nothing to help. They do nothing to meet me halfway. I have had Zoom calls, people in my office, and again, I'm telling you, if it's not the same letter, it's close. For 5, 6, 7 years, we oppose it. We oppose it. We don't like it. It's a mandate. We don't like it. I understand, but at the end of the day, this is hurting thousands of people. We are no closer to a cure. There are people in this body who have had to pay tens of thousands of dollars and had to fight tooth and nail in this body to get another round of antibiotics because they were only going to get one round covered for 10 days. We know that's not working. And a lot of people, quite frankly, they don't have the capital and the access to do that. And, you know, they end up, as we all know, I mean, you guys are members of a fantastic committee. I mean, I'm sure you've heard it more than me. On a couch, in pain, can't get up, can't go to work, you know, and yeah, I just think that unfortunately, mandating this is the way that we're going to fix it, and we're going to have to fix it through this body, because clearly the agencies aren't, the health department isn't coming to the table. So I'm sorry, Doug. I don't know if I get kind of wound up on this one, so I don't know if I 100% answered, but.
I think there's a lot of appreciation for your passion, and seeing no further questions, this does conclude this bill hearing.
Thank you, colleagues.
Thank you for your continued work in this space. This does conclude the bill hearing on House Bill 1375. We are now going to move to House Bill 1565. This is Public Health, Obesity Management and Treatment Programs, Healthy Maryland for Everybody. Delegate Miller, if you want to come to the table and bring your panel, and you can begin your testimony when you're ready.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health Committee. I am Delegate April Miller, representing Frederick County. I am here today to introduce House Bill 1565, which requires the State Employee and Retiree Health and Welfare Benefits Program and certain private insurers to provide comprehensive evidence-based coverage for the treatment of obesity. As many of you recall from my testimony in 2025 on similar legislation, obesity is not a moral failing or lack of willpower. It is a complex, chronic, and treatable disease. In Maryland, over 34% of adults are currently living with obesity, a number that has tripled over the last 4 decades. House Bill 1565 is designed to provide these Marylanders with a medically supervised pathway to health before they develop life-threatening complications like type 2 diabetes, stroke, or heart disease. By failing to provide insurance coverage for FDA-approved medically supervised obesity treatments, we have inadvertently created a dangerous black market for weight loss. We have the Wild West of compounding. Without insurance coverage, many patients are turning to unreliable online sources or unlicensed medical spas for compounded versions of GLP-1 medication. And as of early 2026, the FDA has received over 1,000 adverse event reports related to compounded medications, including hospitalizations due to dosing errors and the use of unapproved salt versions of these drugs. Patients are self-administering medications without the oversight of a physician. Without a doctor to monitor metabolic markers, liver function, and kidney health, Marylanders are risking liver toxicity and severe GI disorders in their quest for health. This bill mandates that treatment happen within the care of a licensed physician utilizing only FDA-approved medications and evidence-based behavioral modifications. We must bring these patients back into the safety of the clinical setting. And we cannot talk about an obesity epidemic without acknowledging how we got here. For decades, a combination of misguided government recommendations and aggressive food industry marketing has reshaped the American metabolism. Since the 1980s, government-issued food pyramids heavily emphasize high carbohydrate I can say it, high carbohydrate, see, I don't like them, intake while demonizing healthy fats. This shifted the American diet toward processed grains and hidden sugars, which we now know are the primary drivers of insulin resistance and chronic obesity. The food industry has engineered hyper-palatable, ultra-processed foods designed to override the body's natural satiety signals. When the government and the market create an environment that facilitates a disease, the government has a responsibility to provide a pathway to treatment. The fiscal and policy note estimates significant costs for the state employee program, and I am very sensitive to that. However, as I argued last year, this is a matter of pay now or pay later. The cost of treating the complications of obesity, dialysis for diabetes, long-term care for stroke victims, and cardiac surgeries is exponentially higher than the cost of prevention. And recent data shows that for every 10% reduction in weight, a patient's total health care costs drop by an average of $2,200 per year. I also want to emphasize that I am only mandating that insurance companies will no longer be able to do a blanket non-coverage of this class of FDA-approved medications. I am not mandating full no-cost coverage. The formulary list, amount covered, co-payments, prior authorizations would all be handled at the negotiated contract level. It will also prevent the yo-yoing in coverage if insurance changes. It is devastating for a person to be successful on this medication and then have it ripped away from them. I would also like to address that there are significant potential side effects to these medications, including on vision, which need to be discussed between doctors and patients, and that is why this bill presents a comprehensive approach to treating the whole patient. Will we find that delaying treatment with these medications until patients are diabetic or in a chronic disease state, that the drastic changes in blood sugar or blood pressure actually increase the risk for side effects? For example, we now know that in the first year of treating certain high-risk patient populations with diabetes with the GLP-1, their risk of diabetic retinopathy initially increases if there is a rapid drop in their A1C level. They should be receiving pre-treatment dilated exams and repeat dilations between the 3 and 6 month mark from the onset of therapy. Importantly, over the long term, though, there is a 24.2% lowering of the risk of blindness from proliferative diabetic retinopathy with the medications. House Bill 1565 is about more than just a number on a scale. It's about safety, accountability, and equity. It ensures that a Marylander's zip code or bank account balance doesn't determine whether they receive a safe FDA-approved treatment or a risky back alley alternative. And I want to leave you with some thoughts from a recent patient experience that I had. The patient told me that their insurance did not cover GLP-1s for her struggles with obesity unless you were diabetic, and that she tried repeatedly to make herself become diabetic. And the last time she was tested, she was disappointed that it had not worked. So I urge a favorable report on House Bill 1565. Let's stop treating obesity as an option and start treating it as the medical condition that it is. And then I'm going to I'll send you, I have a lot, there are so many medical conditions that are actually helped by the medications in addition to, I will send you all the list, as I'm sure you might already know them, but I will make sure you have them, so I don't have to read them all to you. Thank you. You would like to, do you want to go? Sure. Yeah.
Thank you, Madam Chair, Vice Chair, and members of the committee. My name is Dr. Rachel Badabiel. I'm a Maryland physician, board certified in obesity medicine, a researcher, and a patient living with obesity. I am testifying today in my personal capacity. Thank you for the opportunity to provide testimony in support of House Bill 1565. For most of my life, I tried everything we advise patients with obesity to do. I exercised, I tracked what I ate, and tried to follow healthy habits. Yet my body constantly fought me. I still remember as a resident counseling a patient about diet and exercise while knowing full well I had spent years doing those same things myself with little success. That moment forced me to confront what we now understand very clearly about obesity. It is not a failure of willpower. It is a chronic disease driven by complex biology, hormones, metabolism, brain signaling, genetics, and environment. When treatment became available to me, first surgery and later GLP-1 medications, the healthy behaviors I had practiced for years finally worked because my biology and my effort were aligned. I've lost a significant amount of weight and seen improvements in my metabolic health. But no single intervention was the answer for me. Like any chronic disease, effective obesity treatment requires comprehensive care. I see an obesity medicine specialist, get mental health support, and see dietitians. Yet so many Maryland families lack access to exactly this. Insurance routinely refuses to cover anti-obesity medications, and mental health care and nutrition counseling remain unaffordable. We tell patients to lose weight to prevent diabetes, heart disease, cancer, and so many other conditions, and then deny them the treatments that make that possible. If a patient has asthma, we don't tell them to try harder to breathe. We ensure they have access to the medications they need. People living with obesity deserve that same standard of care. House Bill 1565 helps make that possible. When we treat obesity effectively, we prevent chronic disease, improve quality of life, and reduce long-term healthcare costs. As a physician and a patient, I respectfully urge a favorable report on House Bill 1565 to ensure Marylanders living with obesity have access to the evidence-based care they deserve. Thank you.
Thank you, Madam Chair, Vice Chair, and members of the House Health Committee. My name is Monica Bilger, and I'm the Director of State Government Affairs for the American Diabetes Association. On behalf of Marylanders living with obesity and those trying to delay or prevent the onset of type 2, we are in strong support of House Bill 1565 because we believe resolutely that the choice in front of us is to cover obesity early or continue to fund over 200 costly comorbidities and other issues in ever-rising perpetuity. The trends tell us whatever we're doing is not working for Marylanders. Prevalence of diabetes and obesity have worsened over the past decade, and rates of these intersecting diseases continue to rise. Maryland is consistently at the top half of the U.S. with highest diabetes and obesity prevalence rates. Without further intervention, over 60% of today's toddlers will have obesity by age 35. What does that mean for tomorrow's workforce when today excess body weight affects 64% of U.S. workers, costing employers and employees over $425 billion in lost productivity? While medication costs remain a key consideration, emerging evidence suggests the GLP-1s have substantial potential to reduce long-term healthcare spending and improve overall health, including cutting risks of adults with prediabetes and overweight and obesity from developing type 2 by 94%. Weight loss achieved through comprehensive care, including lifestyle support, medications, procedures, can generate significant savings for employers. Annual medical cost reductions of $238 to $752 for just 1 point decrease in BMI, as well as fewer missed workdays due to illness or injury. ADA recommends, based on our 2026 standards of care, comprehensive access to coverage, including centered obesity treatment to urgently address this epidemic, but also the rising cost of chronic disease in this country and in this state. And for that, we request a favorable report for House Bill 1565. Thank you.
Thank you very much for your testimony. I'm going to open it up for questions from the members. Are there any questions for the sponsor or her panel? Seeing none, it's Delegate Taveras.
Thank you. Thank you for this bill. Were you able to see something that was launched in Forbes, I want to say 2 or 3 days ago, regarding the fact that there were additional side effects that led to death and suicide?
Yes, and that's why I said it needs to be partnered with doctors' care, and we need to be able to study the side effects and see what's going on, and they need to have a comprehensive report. But yes, and I understand there's some issues as far as the manufacturer as well. Yes.
Thank you. Can I just follow up real quick with one thing? I just also want to make a note that not everyone who's overweight is unhealthy, right? And I think that there is a cultural issue, like of beauty. Some people prefer thickness. Do you not think that that is not an issue of how this may be presented to people who, I don't know, do you think that that may be an issue in presenting this?
Not at all. I think this actually helps because with the continued care of a physician, if I go to the doctor, my blood pressure's up, my cholesterol indicators are bad, my blood sugar is borderline, but I'm not in a diabetic state or approaching type 2 diabetes, and I can have medication that help treat it, that's a conversation that I have with my doctor based on my risk individually, which is why I said that's why this bill is so important, because those conversations are not happening. And patients are getting it from either compounded pharmacy, there's Costco that they can get it from with an online provider,
I just wanted to make note that the issue
It's one question, one answer.
sorry.
No, thank you, but thank you so much.
Oh, sorry.
That's all right. Delegate Alston, followed by Delegate Kaufman.
Thank you, Madam Chair, and thank you, Delegate Miller, for this bill. Obesity is a very serious problem in this country. And can you speak to all of I know you've talked about high blood pressure and diabetes, but there are other health risks like breathing problems that may not present as actual diseases because of the weight, problems with people's knees and their ability to walk because their frame is carrying so much extra weight. And you know what, you don't need to speak to it. I'm actually speaking from my own personal experience because I'm over 100 pounds heavier than I was at my normal weight, and I weigh more now than I did when I gave birth to my daughter. So I'm very grateful for this bill because 2 weeks ago when I went to the pharmacy to buy the, whatever it's called, I don't want to publicize the name, but one of the approved GLP-1s, it was $1,670 some for a month's worth of supply, which is not affordable for regular people. But fortunately, I was told about a prescription discount card that brought it down to $200, which was more reasonable. But are these rates affordable for regular people? And what can you tell us about how it's been helpful, since I have to ask a question and not just pontificate? Thank you very much.
I do want to just note that every body is beautiful. And I felt certainly myself when I was carrying a lot more weight before I utilized the support of this medication. It is helpful. I did want to live to see my children, and this medication has been profound in decreasing all the comorbidities that are evidence-based, from breathing difficulties to your point, lowering blood pressure. The list is endless, and what's wonderful is it is evolving, and we are continuing to learn more about the significant impact of these medications, and in combination, of course, with the other ways to remain healthy with food and nutrition and physical activity. All of those are not something that we're pushing to the side. It is a comprehensive bill. But of course, what we've seen and what we're evolving and what we're learning is that these medications, and what we're experiencing, I think all three of us on this panel, is the proof of what it feels like to be significantly overweight and then have the ability to have that disease state, because it is, and for many of us, a disease state that we cannot help, improved with that additional effort.
Delegate Kaufman, followed by Delegate Gazzoni.
Yes, one of the individuals was trying to say something, and we have a strict rule, but I did want to, was there something that you would like to add that you weren't able to say earlier? Because of our answer. Okay, that's what I thought so, but I just wanted to make sure.
Delegate Gazzoni.
Thank you, Madam Chair. Did you guys get a chance to look at the letter from the League of Life and Health Insurance folks?
Yes, and I've been working on with them with some of the technical, especially technical corrections and amendments, yes.
Okay, because one of the things that they note in here is that the experience of other states that have mandated GLP-1 coverage have shown that the initial cost projections are significantly underestimate the uptake, which obviously means that it's cost more and rates go up sort of in the thing. North Carolina apparently especially. So I'm just curious, and then they go on towards the end to talk about trying to figure out how to do a study that could maybe be a little bit more accurate. So just curious where you guys are on that. And I'd also note that I'm fairly sure that I'm speaking the truth here, that I think it was Howard County, because otherwise I probably wouldn't have heard about it. Their school system had to take it out of their plan because the cost impact was so high. So mostly I'm just asking you about like how you see, you might be able to address this sort of going forward, the challenge around cost estimates and.
Definitely challenge around cost estimates. And like I said, I'm working on, with a couple different groups on possibly some amendments to be able to either rein them in or be more specific about how that. We had the issue last year as far as when you say coverage, what does coverage mean, right? So coverage can mean a variety of things, but it depends on the initial contract that you have. So I'm not sure what Howard County had with the contract with their medications. If they were doing full coverage, that's very expensive to do. If you are doing either partial coverage, what that does is that not having the blanket non-coverage lets you be able to take advantage of the manufacturer's coupons. A lot of that they have, or from a coupon site that significantly lowers the cost for the patients at then no additional cost, or not as much of an additional cost to the insurance company or in the school system. They're usually self-insured. So that's part of the issue with school systems as well. But when you can use that, the coupon, a lot of times they say that you cannot use it if your insurance doesn't cover it at all. And that's the issue that I personally ran into, where it just became unaffordable, and that's where you have the over $1,000 price. Whereas if your insurance does have some kind of coverage, then that would be brought down to like the $200 or less, even less, $50 some, depending on the medications. There are some medications that are now opening up the coupons if the insurance doesn't cover it, but it's more rare that you have that happen. So that's why it's hard as far as the cost estimate, because of it's so dependent on that insurance contract. And if you went for full mandated coverage is a very big difference than just some.
Can I do a follow-up? Okay, sorry. Then I won't. Thank you.
Seeing no more questions, I just want to say that, we do have a fiscal note in front of us.
Yes.
That says tens of millions of dollars.
Yes, it does.
That is a challenge.
Yes.
But I want you to know that we take this very seriously. We passed a bill earlier in the session that authorized our Department of Health to apply for a waiver should the federal government decide that they're going to, add these to their schedule. We have, I believe, 2 GLPs before the Prescription Drug Affordability Board, one in the first cycle, one in the second cycle. So, I don't know that this is the path, but we appreciate and understand the concern and the reality of ensuring that we are addressing obesity management as a chronic illness and not as where others have previously treated as some sort of personal failing. And it is real and it is chronic, and we will continue as a body to try and figure out how we can best ensure that Marylanders have the care that they need. I will also mention, because we are often terrible about this, that we only control a small percentage of the market, that we have no control over ERISA plans, we have no control over, employer-based insurance. So I just want to make sure, as we're having these conversations, that we're being very clear about what that we are doing all that we can with what we do actually can control. So I do want to thank you very much for your testimony today and for your continued advocacy. This does conclude the bill hearing on House Bill 1565, and we are going to go now to House Bill 1380. So this is health insurance prescriptions for gender-affirming care and hormone therapy coverage and dispensing requirements. Delegate Fair, if you want to come to the table and bring your panel, and you can begin your testimony.
Thank you, Madam Chair. Chair Bagnell, Vice Chair Cullison, and members of the Health Committee, for the record, Delegate Chris Fair here to present House Bill 1380. Under current law, patients whose providers have determined that it is clinically appropriate to be on a hormone-related medication for 12 months can only receive insurance coverage for a 1 to 3 month supply. For many Marylanders, including folks who live in rural areas or who have demanding work and family schedules, having to go through pro forma follow-up appointments to get a rubber stamp solely for insurance purposes before the next batch is dispensed can be a significant hurdle that often leads to disruptions in care. The same is true for multiple pharmacy visits. Supply chain issues and federal actions limiting coverage have also created significant uncertainty for those people who use these medications, again, leading to disruptions in necessary medication and intense panic as patients try to figure out how to maintain access to their care. This is especially the case for transgender people who are in the crosshairs of an antagonistic elected official, but also applies to those experiencing other hormone-related conditions. House Bill 1380 attempts to ease some of these barriers should a provider decide that it is clinically appropriate to prescribe a 12-month supply of a qualifying hormone-related medication to a patient, and insurers that ordinarily cover the medication determine there are no dispensing shortages or other challenges, then House Bill 1380 requires those insurers to cover a 12-month supply of that medication and allows pharmacists to dispense it. This is not unprecedented. Maryland has already implemented a very similar program for 6-month coverage and dispensing of birth control with 2016's Contraceptive Equity Act and 2018's follow-up that extended coverage to 12 months, both signed by previous Governor Larry Hogan. The League of Life and Health Insurers of Maryland argues that the bill is redundant, overbroad, and has no safeguards for patients or providers, and that it will lead to waste, increase in premium costs, and disruptions in utilization management. While I welcome the opportunity to work with the League on these issues, the text of the bill directly addresses the League's concerns, though I am open to crafting amendments in partnership with them, addressing the League's opposition directly. We also met with Care First today to have a discussion regarding their concerns, and they are reevaluating those concerns to understand whether or not they can support this bill with or without amendments. House Bill 1380, does not mandate coverage of any particular medication or change how much money is charged per unit of medication. A company will receive the same amount of money as it does under current law, and it is clear about what types of medication qualify under the bill for both hormone care and gender-affirming treatment, with specific references to Health General 15-151. The bill does not prevent a provider from determining that a smaller supply is more medically appropriate for the patient, allowing for necessary clinical monitoring and lab work to ensure safety and proper dosage without waste. 3, the bill maintains utilization management authority, provides flexibility to insurers in the event of acute dispensing shortages, includes guardrails to ensure responsible dispensing with regard to the plan year start and end dates, and expressly limits supplies of controlled substances to comply with federal law. 4, the bill goes into effect on January 1st, 2027, in alignment with the next plan year to avoid mid-year implementation challenges to insurers. 5, a letter we received from Douglas Jacobs, Executive Director of the Maryland Health Care Commission, confirmed that MHCC, quote, does not believe there would be a measurable increase to premiums for House Bill 1380. Finally, I have received technical guidance from the Maryland Insurance Administration and will be submitting amendments responsive to ensure clarity and MIA's ability to enforce the new requirements as intended. House Bill 1380 will have a big impact on Marylanders experiencing menopause, polycystic ovary syndrome, thyroid deficiencies, hormonal imbalances, chronic menstrual irregularities, and gender dysphoria. Coverage of a 12-month supply and authority to dispense that supply will create the stability and predictability for patients whose providers determine they need the care for that long. House Bill 1380 removes unnecessary hurdles to essential medications that eases patients' anxieties about the shortages and disruptions. And it does so while mitigating insurers' concerns and without any increase to Maryland's premiums. For these reasons, I respectfully request a favorable report on House Bill 1380. Thank you, Madam Chair. Who wants to go first? You want to go first? Please, Tina, go ahead.
Okay. Good afternoon, Chair Bagnell, Vice Chair Cullison, members of the House Health Committee. My name is Tina Jones. I am transgender, and I support HB 1380. I'm sure many of you have already reviewed the research literature that overwhelmingly supports the use of hormone replacement therapy in transgender and non-binary people. The Trevor Project, New England Journal of Medicine, Stanford University School of Medicine, and our own Johns Hopkins University School of Medicine are among the hundreds of scientific organizations which have validated that HRT improves the quality of life for transgender and non-binary people by reducing depression, anxiety, and suicide. These medications are truly life-changing and life-saving. But that's not why I'm here. I'm here to share my personal experience with HRT and why it's important these vital medications remain consistently available in the future. I can personally attest to the benefits identified through research. I experience less depression and less anxiety. I no longer have suicidal ideations, something that is very important to me as a person who has survived a suicide attempt prior to HRT. Because of the availability of HRT medications, I have a better quality of life, or as my wife says, I'm a happier, better person because of it. I have also experienced difficulties in ensuring a consistent supply of HRT on the Eastern Shore where I live. In the last 3 years, I have changed HRT providers 4 times, not because I wanted to, but because the providers left the region or stopped providing HRT services. Today, there are fewer providers, not more, on the shore. It takes longer to find a new provider, and when you do, it takes longer to get an appointment. Each time this happens, I question whether I will run out of medication prior to getting my next refill. I don't want to face the possibility of having to go out on the black market to purchase HRT, something I have done in the past to survive. Supporting HB 1380 will go a long way in assuring that I do not face the risk of running out of my necessary medication. Please support HB 1380.
Good afternoon. Robin Elliott. I'm here today on behalf of the American College of Nurse Midwives and the Women's Law Center of Maryland. Many of you will not be surprised to know that I was the lobbyist who worked on the 2016 and 2018 contraceptive bill that Delegate Fair mentioned. This bill has a lot of the same elements. I recognize a lot of the language. At the core, this is about ensuring continuity of care and access to care for medications where there are difficulties in maintaining the provider base. And this is something that can be done. We have seen with the contraceptive bill, now more than half the states have adopted similar legislation. And the reason is because if a provider feels comfortable with writing a prescription for a medication for 12 months, then the pharmacist should be able to dispense it and it should be covered. That is basic access to care. We ask for a favorable report and we are very happy to work with Delegate Fair and the committee.
I am Dana Mooney, a Frederick County, Maryland resident, parent of a transgender teenager, and president of PFLAG Frederick, which is a local chapter of PFLAG, a nationwide organization dedicated to supporting and advocating for LGBTQ+ people and those who love them. And I am here in support of HB 1380. Many other parents and caregivers I meet with have shared that they moved to Maryland for a safer place for their LGBTQ+ family. Yet as Maryland parents of trans youth, we talk about what we will do if it becomes unsafe. Are we preparing to leave the country? And how will we continue to get gender-affirming and life-saving care for our children in the future? If you are a parent or caregiver and you have ever watched your child struggle with fear, anxiety, depression, self-image, illness, or grief, and then you have seen them find a new skill or hobby or friend or treatment that has brought them joy and growth and health, you might know something of what it is like to see our children receive the care and medication they need to be their whole self. And the pride we feel when they bravely step up to share their truth, even when that truth is frequently met with hate and misunderstanding from others. It takes time and perseverance to find the right doctors, therapists, and medications. The idea that our children and friends could, without warning, lose access to their gender-affirming care is horrifying. Missed refills can disrupt physical and emotional well-being, create anxiety about shortages, and add stress and mental health concerns. Knowing that our trans children and our trans friends could have access to their needed medication for 12 months would greatly ease the minds and hearts of our families during a time where we are seeing the rights of transgender individuals stripped away. Please keep Maryland a place where our children, our friends, and our residents can be safe, can be themselves, and can get access to their medically necessary care and medications. Thank you.
Thank you for your testimony. And you do have one virtual witness, so we'll go ahead and bring up your virtual witness, Diana Nazal, if you want to unmute and begin your testimony.
Thank you very much, Madam Chair and members of the committee. My name is Diana Nazal, and I am a resident of Middleton, Maryland, and a constituent of District 4. I'm writing to urge, I speak on behalf of the favorable report for House Bill 1380. I'm a transgender woman myself, a parent of one, and a disabled combat veteran. After serving a great nation for over 17 years, I was just recently forced out of the United States Army this past January, along with numerous other transgender service members. For those of us who are drummed out, the process to go from the military health system to the civilian healthcare system has been rough, to say the least. In the last few months, I've had to work to find a new medical provider who can accept new patients. This includes various phone calls, voicemails, emails, and including in-person appointments, just to affirm or deny any type of future potential care while I'm in the middle of transitioning from the state of Kansas to the state of Maryland. Even with a 90-day supply of hormone therapy, the fear and uncertainty of job insecurity, lack of providers, and medical care plans changing, being able to maintain a 12-month supply of medication would give significant breathing room for someone to upkeep their health, allowing them to focus on their next steps. House Bill 1380 can provide significant relief to patients without the need to request time off from work, adjustment for childcare, or arrangement for transportation. Even those who are on 90-day supplies, this means at least 4 times a year they have to adjust their schedules for work, childcare, career ambitions, as potentially transportation for those who are restricted on movement. House Bill 1380 is a strong means for Maryland to uphold where their federal systems are peeling back, and as a message to all Marylanders of all walks of life that our health matters. For these reasons, I respectfully urge you to give House Bill 1380 a favorable report. Thank you very much.
Thank you for your testimony, and thank you for all of you for sharing your personal stories today. I'm going to open it up for questions from the members. Are there any questions? Delegate Kaufman.
Yes, this question is for Delegate Fair. Are there other communities besides those using hormone replacement therapy being targeted or scrutinized this way by the federal government?
That's a great question, Delegate. The short answer is no. We see the government targeting certain medications, and they're looking at certainly some medicines differently, but the real hyperfixation on the attempt to remove access to medically necessary care is not seen in any other community in our country.
Thank you, Madam Chair. Thank you, Delegate Fair.
Delegate Johnson, followed by Delegate Tibb.
Thank you, Madam Chair. Delegate, in the letter, the League of Life and Health Insurers, they say they don't see the need for this bill as Maryland carriers are already covering these drugs and services. Can you talk to us a little bit about that?
Yeah, the concern is not about the coverage. We always appreciate that our insurers have really been at the forefront of making sure that we provide access to these medications. The problem that we're having is that because of a lot of inconsistencies, especially from the federal government, there's a lot of risk and there's a lot of disruption in the amount of time that they have to wait in order to get more, they need to get their prescription re-upped. And as medical providers are being targeted and pushed out of business because of this, there's trans individuals like Ms. Jones mentioned in her testimony are struggling to find new providers, which means that they're going longer and longer timeframes without having access to their medically necessary HRT. And so really what this comes down to is not about the access question, it's a question of the duration of how long the prescription would be provided.
Thank you for clearing that up. Thank you, Madam Chair.
Thank you.
Delegate Tavada.
Thank you, Madam Chair. It says here on page 3 that an entity subject to this section may not require an enrollee to accept a 12-month supply. Has that been a problem in the past where enrollees are being forced to take more?
No, I think that language is just specifically written that way so that it's clear that the clinician, the medical provider that you're actually seeing, has the option to prescribe. If they believe that this is the medically correct thing to do for their patient, they have the option to do that, and that they're not required to do it. So we're not putting a requirement on them to say, if a patient comes to you and says, I want a 12-month prescription, that we absolutely give it to them every time. This is a conversation that the doctor has with their patient and decides if that's in the best interest of the patient.
Okay, can I just follow up real quick? Thank you. On page 2, I just have a quick question, and I don't know if there's anybody here who can answer it, and if not, just let me know. What makes line 10 and 11 so special that it does not, it says here that qualifying prescriptions does not include prescriptions for a glucagon-like peptide 1 or glucagon-like peptide 1 receptor antagonist? What does that language signifies? What is this, why is that special?
Do you know? No. We'll have to get back to you on that.
Okay,
I'll
thank
get you
you.
the answer for that, Delegate. Thank you.
Seeing no further questions, I just wanted to know if you knew, we do 12-month supplies of things like birth control, like that's already a regular practice. So this would not be outside of a normal practice. This is just addressing a potential supply issue. Is that my understanding?
Yes, that's correct.
Okay, so we do have precedent. Delegate Kazoni.
Coming with a late question, thank you, Madam Chair. I had a question for Ms. Neisel. I'm just curious, having been in the military, if you had challenges with either getting the medication, access to it essentially, and/or how long a prescription would last, and whether or not you're seeing a difference between having your military career and now.
I'm not sure how much I could speak on for others, but when it came to myself, I was able to receive one final prescription while on active duty, and then they forwarded my health care from a military service provider to a civilian medical provider that was approximately an hour and a half eastbound where I was previously stationed at. So every time I had to go in for an appointment, we're talking about a 2.5 hour drive plus or minus. And that was 2 to 3 appointments before I was able to start moving my household goods and my daughter here to the state of Maryland. With that in mind, the last appointment I had with them, it was a significant delay from my previous medication 90-day prescription to a new 90-day prescription. It went from a singular to a double amount. What that means is that I received my refill about plus or minus November of last year. I then had to transfer from one civilian-based pharmacy to another civilian pharmacy in between 2 different states that was already approved by the medical practitioner. So it went from we might get medication to, we will have medication to, you might have medication in another state if this business even allows it to happen. And when I first initially moved over here to see about housing, that's when I was able to get my second refill. And I'm still waiting for my third and potentially final refill, dependent on what's going on through the VA healthcare system myself.
Thank you.
Thank you very much for your testimony. This does conclude the hearing on House Bill 1380. Thank you all for being here. We are now going to move to House Bill 1435. This is health insurance required coverage, hormone-related care. Delegate Spiegel, if you want to come to the table and bring your panel, and you can begin your testimony when you're ready.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Okay to begin?
Are you double teaming us, Delegate Spiegel?
We are in fact, Madam Vice Chair. We're proud to be doing so, and I'm going to explain the circumstances around that in a moment. But for the record, Delegate Ryan Spiegel here on behalf of House Bill 1435, which would require health insurance coverage for medically appropriate treatments for menopause and perimenopause. And I have to say at the outset, the idea for this bill came to me late in session from advocates, including our panelist who's joined us today. So the bill was filed under my name to get it dropped by the deadline. And while I am proud to be an ally on this issue and someone with family members and friends who have dealt with symptoms and conditions associated with perimenopause and menopause, I humbly recognize that perhaps I am not the most appropriate spokesperson for this bill. And so I am very proud to partner with Delegate Rose on a bipartisan basis as co-primary sponsors of this bill, and to defer to her expertise and her advocacy on this matter. And I must say I'm very grateful for her leadership on this. So I am going to just hand it over to her to take the lead, but I just want to make a couple of other introductory remarks, if I may. First, I understand the committee already had some important discussions about the need for coverage for perimenopause and menopause earlier this afternoon. I think our bill is an important complement to the Speaker's bill, HB 1365, and I appreciate the fact that you all have been focusing so much attention on this important issue. Secondly, I just want to also mention that the Maryland Insurance Administration has provided us with some comments suggesting some technical tweaks to better align the language of the bill with technical terms elsewhere in the code, and we will provide that language to the committee if the committee wants to move forward with the bill and sees an amendment as appropriate. But those are really just technical suggestions. So in closing, I'll say the bill positions Maryland as a national leader in equitable, science-based health care. And with that, I'm happy to hand it over to my partner here, Delegate Rose. Thank you.
Thank you. Good afternoon. Thank you for letting me participate in this bill. This legislation would require insurance companies to cover treatment for perimenopause and menopause. This issue is of paramount importance to help women deal with this legitimate health issue. This is not just for older women. Women of all ages may find themselves having an early hysterectomy that would immediately plunge them into menopause. Women dealing with these hormonal issues can be affected physically, mentally, and emotionally. In 2003, the FDA declared hormone replacement therapy as unsafe. In 2025, they rescinded that warning, saying that updated science showed that earlier heart issues, dementia risks, and breast cancer risks were greatly overstated. Women who have gone through perimenopause and menopause have suffered needlessly sometimes for 23 years. HRT can provide actually heart benefits, help with metabolic systems, reduce diabetes, and support neurological functions. Women who have providers that will prescribe HRT have healthier, stronger bones, according to the most latest data. We just need physicians to catch up with this new data. Insurance companies need to ensure that these therapies are an accepted standard of practice. As an aside, just to my own personal story is, I went to, when I first started down this lovely road, I went to my physician, my gynecologist, and I was told, we don't do that anymore. We don't do hormone replacement therapy anymore. Well, I was a little frustrated with that, and I actually went back to another doctor in the same practice, but in another location. And she assured me that, yes, she would work with me and she would help me deal with these symptoms. So there's definitely an inconsistency, and I've heard that from friends as well. I've had a couple friends that have gone through hysterectomies, and that can be particularly challenging because you just go straight from, there's not even perimenopause, it's straight into menopause. It's important to include perimenopause because it is sometimes not dealt with because it does not follow the rule of a lack of a menstrual cycle for 1 full year. You could go for 10 or 11 months and then have a cycle, starting the whole process over again. What is then not addressed sometimes are the myriad of issues that women deal with in their health and well-being, already to the point where a physician's care could lessen those symptoms and help a woman transition from perimenopause into full menopause with a lot more relief. Hot flashes, insomnia, mood changes, and weight gain can have long-term health implications. Perimenopause and menopause have been overlooked in research and healthcare policy because women in midlife have been often underrepresented and undervalued in medicine. While plans sometimes cover hormone-related therapies, this bill will standardize coverage and reduce administrative barriers. This is not a political issue. It's about recognizing that half our population deserves proper health care. I will note that Illinois, Louisiana, and New Jersey, I think, is going to sign a bill into law this week. Oregon, Washington, New York, California, and Massachusetts have pending bills. And it's also been reported that Michigan, Florida, Georgia, Virginia are also looking at this legislation. So with this change at the end of 2025, this is obviously a very important issue, and I hope that you will consider it and provide a favorable report. Thank you.
Madam Chair, Madam Vice Chair, and members of the committee, thank you for the opportunity to testify in strong support of HB 1435. I'm Andre Marciniak, live in Southern Maryland, and I'm here out of concern for my wife and my 4 daughters. My support for this bill began when my wife encountered needless obstacles accessing basic hormonal care, obstacles that reflect what countless Maryland women face every day. There are over 1 million women in Maryland who experience perimenopause and menopause. Perimenopause and menopause are universal physiological stages, yet our healthcare system treats essential hormonal care as optional and discretionary. Women are subjected to denials, inconsistent standards, and inflated out-of-pocket costs for treatments that are medically proven and widely recommended. In contrast, comparable therapies for men are frequently covered with minimal barriers. And these differences are rooted not in science, but in policy gaps, outdated assumptions, and decades of uneven research investment. When women receive appropriate hormonal care, the impact is immediate and substantial: better sleep, improved cognitive function, greater stability, and stronger participation at work and at home. These are core health needs, not luxuries. HB 1435 sets consistent evidence-based coverage rules so clinicians, not insurers, determine care. It ensures women like my wife are no longer penalized for normal physiological stages. For the benefit of my wife, my daughters, and women of Maryland, I ask for your favorable report on HB 1435. And I'd like to thank Delegate Spiegel, Delegate Rose, Delegate Werman, and Kaufman for your leadership on this bill. Thank you.
Thank you for your testimony. We're going to go to your virtual witnesses now. We'll start with Dr. Nadia Surdar. If you want to go ahead and unmute and begin your testimony. All right, so let the record reflect Dr. Surdar is not in the waiting room, so we'll go to Wen Shen. If you want to unmute and begin your testimony. Ms. Wen Shen? Are you able to hear us? Ms. Shen, can you unmute and begin your testimony?
Can you hear me?
Yes, we can, but I think you
Okay.
have
Good
you still
afternoon,
have
Chair
the live
Bagnall
stream
and
on.
Vice Chair Collison and members of the committee. I am Dr. Wen Shen. Yes.
You need to turn off your
And I
live
am
stream.
unmuted.
Yes, but turn off your live stream. You just need to turn off your live stream so that you won't hear yourself.
Can hear you.
So while
Can you hear me now?
Yes.
Okay.
But you still need to turn off your
Okay.
live stream. We can hear it. You hear how you hear
All right.
me and you in the background? You need to turn off that live stream where you're hearing me and you
Yeah.
in the background.
Here we go. I'm an associate professor at the Johns Hopkins School of Medicine, and I am the director of the Women's Wellness and Healthy Aging Program. The views expressed here are my own and do not necessarily reflect the policies or positions of Johns Hopkins University, Johns Hopkins Health System. Thank you for the opportunity to give testimony in support of House Bill 1435, which, if passed, creates easier access to important care for women experiencing menopause. I have been specializing in menopause health for over 20 years, and I am very gratified that the importance of healthcare for women in midlife is being recognized. Women fill multiple roles in the community, business, and as primary caretakers of the family. Healthy women means healthy families. Daily, patients come to see me because their symptoms are severely affecting their quality of life and their relationships with their loved ones. They say they are worried that they are going to lose their jobs. Many of these women who medically qualify for menopause hormone therapy are stymied by lack of insurance coverage and exorbitant costs. Every person born with ovaries will experience menopause. Midlife is an opportunity to evaluate women's health and risk factors caused by low estrogen levels and aging, such as cardiovascular disease, osteoporosis, dementia, autoimmune diseases, cancer, just to name a few. New research has led providers and professional societies to recognize menopause hormone therapies as the gold standard for treatment of menopause symptoms in eligible women. This can have beneficial effects beyond the immediate menopause symptoms. Thank you very much for your attention, and I urge a favorable report on House Bill 1435. Thank you.
Thank you for your testimony and your patience while we figured out the tech. Andrea Giancontieri, if you can go ahead and unmute and begin your testimony.
Absolutely, thank you. Good afternoon, Chair and members of the committee. My name is Andrea Gianconteri. I'm founder of the Whiny Gyny, a patient advocacy platform dedicated to menopause education and access to evidence-based care. Let me start with the simple truth. Menopause impacts everyone who has the privilege to age, or every woman who has the privilege to age. It's a universal life stage, yet our healthcare system treats it like a niche issue. Let me start with a few more things, right? So in my late 40s, I began experiencing a myriad of symptoms: insomnia, night sweats, urinary incontinence, joint pain, tooth sensitivity, metabolic changes, and cognitive changes that affected my ability to compensate for my dyslexia. I went from doctor to doctor trying to figure out what was happening in my body. I had an IUD, so I had no menstrual marker. I saw 9 different providers: my PCP, an orthopedic surgeon, an allergist, a dermatologist, a gynecologist, a urogynecologist, a pelvic floor physical therapist, a dentist, and a periodontist. I paid co-pays that I can't bring myself to add up. And one morning I woke up with dark fine hair covering my cheeks and neck, and I went to the threading salon where an esthetician said, "Oh honey, it's the hormones," that being the first time hormones were referenced as a possible source of what was happening in my body. And that leads me to my favorite line: When an esthetician recognizes menopause before a medical system does, that's not a patient problem, that's a healthcare policy problem. And unfortunately, my experience is not unique. Research shows that an average of 4 providers are seen by a woman seeking care, and apparently I aimed higher because I saw 9. Even when women finally find knowledgeable clinicians, many face insurance companies that force patients to jump through unnecessary hoops, delaying or denying evidence-based treatments such as transdermal menopause hormone therapy. This system doesn't save money. It costs more in repeated appointments, unnecessary diagnostics, lost productivity, and years of untreated symptoms. HB 1435 is an important step toward ensuring patients can access appropriate hormone-related care without unnecessary barriers, because menopause is not elective, it's not cosmetic, it's a population-wide transition. And I'll close with this. Women shouldn't need to see 9 doctors, pay dozens of copays, and a threading appointment to figure out they're in menopause. And they shouldn't need a PhD in insurance billing to treat it. So thank you, and I appreciate your support in favor of this legislation. I will also say I testified in support of both pieces of Massachusetts legislation, and thank you for having me today.
Thank you for your testimony. We have one more virtual witness, and then we'll open it up for questions. Irene Quarshie, if you want to go ahead and unmute and begin your testimony. Irene Quarshie, do you want to go ahead and unmute, and you can begin your testimony? Ms. Quarshie? Oh, there we go. I saw you unmute and then remute. Ms. Quarshie, if you will unmute and begin your testimony.
Hello, thank you very much. Right, so the chairperson and members of the committee, good afternoon. My name is Dr. Quarshie. I'm a general practitioner, a public health researcher at the University of Maryland, and a mother. I'm here today in strong support of House Bill 1435, which requires insurers to provide consistent, non-discriminatory coverage for hormone-related care in Maryland. Over 12% of Maryland's female population may currently be perimenopausal, and it's not simply a story about women in their 50s. Research shows that during this transition, forgetfulness increases 15 to 20%. Rates of depression and anxiety can peak, meaning hormone changes affect not just physical health, but cognitive health and mental well-being. As someone who has experienced firsthand how hormonal shifts can cloud thinking and affects mental health, I can only imagine how much more profound that becomes during a perimenopausal transition. And it's not just a health issue, it's a workforce issue. The country loses $26.6 billion annually in productivity and medical costs tied to menopause symptoms. Nearly 1 in 5 women has considered quitting a job because of these issues. The evidence exists, and so does the clinical guidance. The barrier is coverage. Fewer than 1 in 4 women nationally has full insurance coverage for hormone-related prescriptions. Since this bill 1435 covers that gap, that requires medically necessary care as determined by the treating provider, and that creates accountability through annual reporting to the Medical Insurance Administration, I urge a favorable vote. I believe this will ensure Maryland women receive care that keeps pace with the evidence for a healthier and more productive workforce. Thank you very much.
Thank you for your testimony. I'm going to go ahead and open it up to the members. Are there any questions for this panel? Seeing none, I will just say our speaker agrees, and we actually passed that bill out of this committee this earlier today. So thank you for this really timely and important effort, because we're all going to get to vote on it in just a couple days. So this does actually conclude the hearing on House Bill 1435. We are now going to go to House Bill 1251. Thank you so much for
thank
your
you.
testimony.
Thank you.
Health facilities and health insurance, palliative care, required access and coverage, the Edna G. Neal Palliative Care Act. Delegate Woods, if you want to come to the table and you can begin and bring your panel and you can begin your testimony.
Madam Chair, I do have another person that's also virtual.
Yes, I have a Gwendolyn DeVille, and
Correct.
virtual will bring them up as part of your sponsor panel.
All right, thank you so much. Thank you, Madam Chair, Madam Vice Chair, and members of my number 2 favorite committee here in the Maryland General Assembly. I'm Delegate Jamila Woods, and I'm extremely pleased today to have my intern, Lexi Sens, who is going to present the bill to you all today. Thank you.
Good evening, Chair Bagnell, Vice Chair Collison, and esteemed members of the Health Committee. My name is Lexi Sens, and I'm here to request a favorable report on House Bill 1251, legislation that strengthens access to high-quality palliative care by removing unnecessary hurdles that often stand between families and the support that they desperately need. For far too long, Maryland's with serious illnesses have slipped through the cracks of our healthcare system. Families watch loved ones struggle with unmanaged pain, overwhelming symptoms, and emotional distress. Not because we lack the medical knowledge to help them, but because high-quality access to palliative care remains inconsistent and in many communities unavailable. HB 1251 is our chance to change that. This bill takes a meaningful and overdue step towards ensuring that every Maryland resident, regardless of age, diagnosis, income, or insurance status, can receive the relief, support, and dignity that palliative care provides. It requires hospitals, nursing homes, hospice facilities, and long-term care settings to offer a dedicated palliative care program beginning in 2027. Importantly, it makes it clear that palliative care is not limited to end-of-life care. It is care that improves quality of life at any stage of a serious illness, offered alongside curative treatment and not instead of it. HB 1251 does not create new burdens or weaken existing support standards of care. Instead, it modernizes Maryland's approach to serious illness support so that our policies reflect the realities that patients and families face every day. This bill directs the Maryland Department of Health to establish clear, uniform standards for palliative care delivery, standards that include staffing expectations, training requirements, and quality assurance measures. These are elements that already exist in high-performing programs across the country and are routinely applied to have safe, person-centered care. Just as importantly, HB 1251 preserves Maryland's commitment to high-quality, evidence-based medical practice. Facilities remain flexibility in how they meet the requirement to provide access to a dedicated palliative care program, whether through on-site teams, regional partnerships, tele-palliative services, or formal consultation arrangements. This guarantees that hospitals, nursing homes, and long-term care providers can comply in ways that reflect their size, resources, and community needs without compromising the quality or availability of care. At its heart, this bill is about compassion, dignity, and fairness. It's about making sure that no Marylander faces the hardest moments of illness without the support that they deserve. It's about honoring the legacy of the Edna G. Neal and many others like her through a healthcare system that sees the whole person and not just the disease that they are facing. For these reasons, I respectfully urge the committee to issue a favorable report on House Bill 1251. Marylander families have waited long enough for this level of care. We need to make sure that they no longer have to. And as we move this bill forward, I want to acknowledge that we are actively working with stakeholders on amendments to clarify certain provisions within it. Thank you for your time and consideration.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Venus Jones, and I am here today on behalf of Edna's Love Incorporated in strong support of the Edna G. Neal Palliative Care Act, House Bill 1251. This bill exists because too many Maryland families face serious illness without comfort, clarity, or choice. Edna G. Neal passed away in 2020 after a vigilant fight with leukemia. She lived in St. Mary's County, where palliative care was not an option. As her condition worsened, hospice decisions were made that unintentionally robbed her family and friends of final moments. One last hug, words of wisdom, and the opportunity to say goodbye. Palliative care would not have taken away Edna's hope or treatment. It would have given her comfort, support, and the dignity to transition on her own terms, the same way she lived, surrounded by the people she loved. That is the difference this bill will make. Palliative care is not hospice. It is not end-of-life care only. It is specialized medical care that works alongside treatment to manage pain, symptoms, and stress at any stage of serious illness. Yet access to this care in Maryland depends largely on where someone lives and what insurance they carry. The Edna G. Neal Palliative Care Act, House Bill 1251, ensures that palliative care is offered statewide and covered by all insurers. It provides quality of life, supports families, reduces unnecessary hospitalizations, and saves healthcare dollars while preserving patient choice. This is a compassionate, evidence-based policy. It is fiscally responsible, and most importantly, it's humane. By passing this bill, Maryland has the opportunity to honor Edna's legacy and protect countless families from unnecessary suffering. These last moments to give final wishes without unclarity. I humbly request your support for this bill. Thank you for your time and consideration. Respectfully submitted in service and love, Venus Jones, founder and president of Edna's Love.
Thank you for your testimony. And Delegate Woods, Gwendolyn DeVille is not in the waiting room.
She's not.
So, I just want to commend your star witness on your excellent testimony. Is this the first time you've testified before this committee?
Yes, it is.
All right, well done. Are there any questions for this panel?
They just want to know where you got all of that intelligence.
Are there any questions? Delegate Kaufman.
Yes, I wanted to see if you had a chance to review the letter of opposition from the League of Life and Health Insurers and their statement that insurance companies already cover services associated with palliative care and another mandated benefit which concerns them, and I wanted, what's your response?
And your question was, have we did review the opposition? You were talking about the League of Life and Health
Yes.
Life and Health Insurers of Maryland?
Yes, what's your response to their opposition?
Well, I think one of the most significant things that you've heard both in the intern and in the other testimony is that this bill says that they address it, but not in a uniform approach. And one of the things that we want to see take place is that there is a uniform approach to providing equitable care to everyone, that there aren't questions, that there aren't, you understand what I'm saying? Services aren't being missed because we do not have in succinct what types of services people should receive.
I think it's a good bill. Thank you, Madam Chair.
Thank you so much.
Delegate Martinez.
Thank you, Madam Chair, and thank you, Delegate, for the bill. I actually serve on the Maryland Advisory Council on Serious Illness as the House of Delegates member, and I saw that they submitted a 4-page letter favorable with amendments. Have you had conversations with the council about the series of amendments, and are they part of that stakeholder group you're working with?
And so I can't specifically answer that question, but we are definitely welcoming all of the amendment concerns that people are having, and we are coordinating meetings with all of those who are making recommendations. And I believe that it was stated in the testimony that we are entertaining amendments at this time.
No, it was. I just wanted to ensure that they were part of that stakeholder conversations. If they weren't, to just make sure that you follow up with them because they are the palliative care body for the state, and we do really, really good work collaboratively with providers, with, patients, just everyone. And so just want to make sure they're part of this conversation.
We'll definitely make sure they're part of the conversation. Thank you so much, Delegate.
No, thank you, Delegate.
Thank you, Delegate. And I just want to point out, I know we have a favorable with amendments and one unfavorable panel coming up. But you had said that this was something that they were already doing, but we need a more uniform strategy, but the fiscal note reflects a substantial increase. And so I just wanted to give you an opportunity to speak to the fiscal note if you wanted to.
I cannot speak to the fiscal note at this time. I do want to sit down with those persons that have concerns to see how we can work this out.
Okay, thank you very much.
My
Thank you for your
pleasure.
testimony. We are going to move to, Delegate Gazzoni, sorry.
It always takes me a while to decide if I have a question or not. Thank you, Madam Chair. Could, whomever's best on the panel, could you talk a little bit about the difference between hospice care and palliative care? Because I'm not particularly clear on that.
Yes, ma'am. So primarily, they do go hand in hand. However, once you have entered into hospice, they do stop treating the disease. It is for comfort. Palliative care does allow you to continue your medications or whatever treatments in delaying the disease, as well as releases for comfort as well. And what we're finding is that in the rural areas where you're not as close to the hospital, those options are greatly limited.
Thank you.
Thank you.
Delegate Tavadet.
Wow, I think I just got an answer for it, but I just want to make sure that we go on the record, making sure that we are trying to help be comprehensive. And so I just want to make sure that there's a distinction between palliative care and what you're trying to propose versus pain management clinics, where we often saw other things occurring and being distributed. If you could speak to that.
Sure, thank you so much, Delegate. One of the things that I believe was being articulated when she talked about the difference between like hospice and palliative care, one of the things that this bill wants to ensure is that there are still curative services available, and I think that's extremely significant. Does that answer your question?
No, I mean, what do you mean by that?
That we still provide services to try to help people to lean toward a healing.
Okay, thank you.
My pleasure.
Thank you very much. Seeing no further questions, this concludes this panel. We do have a favorable with an amendment, with amendments and an unfavorable. So if I can bring Peggy Shimoda, Jane Franke, and we've got Benjamin Goldstein virtually. Okay. So if you want to come to the table and begin your testimony when you're ready.
Great. Okay, I guess I'm going to go first. So good afternoon, Chair Bagnall, Vice Chair Collison, and members of the committee. My name is Peggy Shimoda. I'm the Executive Director of the Hospice and Palliative Care Network of Maryland. We're the statewide association representing hospice providers and palliative care partners across Maryland. I have submitted written testimony in support of 1251, and so I'll keep my remarks brief. So our members enthusiastically support the goal of expanding access to palliative care and ensuring that patients and families are aware of the care options that are available to them. Many people understandably confuse palliative and hospice care. Palliative care helps people living with serious illness manage pain, symptoms, and stress while they continue treatment. Hospice care provides similar comfort-focused support when someone is nearing the end of life, excuse me, and treatment shifts from cure to quality of life. Palliative care is reimbursed like other medical services, while hospice is provided through a comprehensive Medicare and Medicaid benefit. We appreciate the bill's emphasis on access, interdisciplinary care, and coverage parity. At the same time, we respectfully request several technical clarifying amendments to ensure licensed hospice programs are not inadvertently subject to duplicative requirements. Hospice providers already operate under comprehensive federal and state standards that require interdisciplinary teams, symptom management, advanced care planning, and family support. Our amendments simply clarify that hospice providers are compliant through their existing interdisciplinary structure and are not required to establish a separate palliative care program. So with these clarifications, we respectfully request a favorable report with the amendments outlined in our written testimony. Thank you so much.
Good afternoon, Chair Bagnall, Vice Chair Colson, and members of the Health Committee. My name is Jane Krinke. I'm here on behalf of the Maryland Hospital Association in support of House Bill 1251 with some amendments. We really appreciate the intent of this legislation to ensure Marylanders facing serious illness have access to high-quality, patient-centered palliative care, and we're happy to work with the sponsor and stakeholders on any changes to the bill. Currently, state regulations require acute general hospitals and special chronic hospitals with 50 or more beds to have a hospital-wide palliative care program, which provides consultation services to patients suffering from pain and symptoms due to a serious illness or condition. This bill expands these requirements for these palliative care programs. We support several of the amendments that were referenced that the Maryland Advisory Council on Serious Illness Care has offered, especially those addressing equity and affordability for insurers and increasing capacity of the workforce. In addition to the council's amendments, we'd ask the committee to consider 2 additional amendments. The first would clarify which hospitals should be included in the definition of a facility. We recommend excluding the specialty hospitals and just focusing on acute care. For example, freestanding psychiatric facilities, their services don't align with the goals of a palliative care program, and they don't have the expertise to manage serious or life-limiting medical conditions. Similarly, a rehabilitation hospital, they do not see palliative care patients. Those patients don't actually meet the CMS conditions of participation for acceptance into these facilities, which require patients to be medically stable and able to participate in intensive therapy. So we recommend just narrowing the scope to those that are currently required to have these programs. We also recommend modifying the language that allows regulations to set minimum standards. We think this is a function of statute and not regulations. And then finally, we'd like to clarify that the facilities, such as hospitals that are already held to regulations, just be able to operate within those regulations. And for those reasons, we request a favorable report on House Bill 1251. Thank you.
Thank you for your testimony. Mr. Ben Goldstein, if you want to unmute and begin your testimony.
Sure. Thank you. Good afternoon, Chair Bagnall, Vice Chair Collison, and members of the Health Committee. My name is Dr. Benjamin Goldstein. I'm a physician who's been practicing palliative care and hospice in Maryland for about 7 years. Every day I care for patients with serious illness, whether it's cancer, heart failure, lung disease. I'm here in support of House Bill 1251 with some amendments as submitted by the Hospice and Palliative Care Network of Maryland. I won't go into a lot of that as Peggy's covered it. I think it's really a wonderful thing for our state. It really improves health equity. This is going to be access for all socioeconomic groups. I think it'll save a lot of money. It will provide much needed support for patients as well. Just kind of a quick story. I have a patient with breast cancer that I'd seen in the hospital, in the clinic. Every time she comes to the clinic in the oncology suite, she has been dealing with a lot of pain. She has lesions in her bones. And I go in there and speak to her and sit down and really, I'm able to spend time with her. I can manage her symptoms with her spine. I have a very holistic view, and as is palliative care. We ask about social issues that are going on, equipment they need. And as an internal medicine doctor by training, I have a lot of knowledge and information that I can provide. So instead of sitting in the cancer center all alone and not sure what's going on with people running in and out of the room, it really gives patients and families the opportunity to talk to someone and have the time to really care and really learn about the patient. So I think it's really something that will only benefit all the patients here in Maryland. It'll definitely provide cost savings. If you really talk to patients about what treatment means and what's coming up ahead, many times they may just not want to do it, as opposed to just telling someone to go down a certain road. It'll provide more comfort at end of life. So I'm hoping that this is really exciting for palliative care in general, and I'm hoping that this will come through with the recommended amendments, and I appreciate everyone's time for having me here. Thank you.
Thank you for your testimony. I'm going to open it up for questions. Are there questions for this panel from the members? Seeing none, thank you very much for your testimony today. We have one more panel. We have unfavorable Dana Kaufman, if you want to come to the table and give your testimony.
Good afternoon, Chair Bagnell, Vice Chair Cullison, members of the committee, Dana Kaufman on behalf of Lifespan Network. And I appreciate the sponsors staff sitting down with me earlier to hear our concerns. And basically, our concerns were a couple technical, but then just overall. The bill references nursing facilities and long-term care facility licenses. There is no license for long-term care facility, so I wasn't sure exactly what that meant. The fiscal note actually references assisted living, which brings in a whole other conversation. But I'm just going to refer to the nursing facility right now. So as far as nursing facilities, you've heard how palliative care is used for treating symptoms. It's curative care. And the mandate that's in the bill, that's for private insurance. So nursing facilities are funded through typically Medicaid, Medicare, not private insurance. So there is no discussion as far as how that would affect the nursing facilities, because at the end of the day, if we're required to have palliative care, how would that be funded? But I also want to point out that nursing facilities, if we do have a resident who typically would be admitted more on a short-term rehab basis that may need palliative care or has a palliative care order or hospice, the nursing facility itself does not provide that. The individual resident contracts for those services with a hospice provider, and then the nursing facility and the hospice provider will and is required to, under federal and state law, enter into a contract, because at that point the nursing facility is providing the room and care, but the hospice provider is responsible for care management. So it was very unclear to me the role then that the nursing facility, if this was a new responsibility that the nursing facility would have to do, which we don't think is appropriate since a hospice provider is more situated for that, and then of course the cost. So thank you.
Thank you for your testimony. Are there any questions from the members for this witness? Delegate Wright.
Thank you, Madam Chair. So I heard what you said, so very good. So currently now, who is paying for the palliative care in our nursing homes? Is that the contract between a private insurance and?
So I always get, even if I've represented this industry for so long, I still get a little bit nervous when I start talking about this. So hospice is a Medicare benefit. Right. So that is who would be paying for the service. Now, and I try to do some research, but it's my understanding too that Medicare pays for hospice, which might include some palliative services, but there's no set chunk of money for palliative services. A lot of times the hospice providers are doing it because it's the right thing to do.
Okay. All right. Thank you. Thank you, Madam Chair.
Thank you very much. Seeing no further questions, this actually concludes the hearing on House Bill 1251. We're now going to go to House Bill 1107. This is Maryland Medical Assistance Program and Health Insurance Required Coverage for Aesthetic Services and Restorative Care for Victims of Domestic Violence, the Healing Our Scars Act. Delegate Martinez, if you want to come to the table and bring your panel. I see that you do have two virtual witnesses, so we'll bring them up.
House Bill 1107.
And you can begin your testimony. All right, and you can begin your testimony.
Thank you so much, Madam Chair and members of the committee. For the record, I am Delegate Ashanti Martinez, here to present House Bill 1107, Maryland Medical Assistance Programs and Health Insurance Required Coverage of Aesthetic Services and Restorative Care for Victims of Domestic Violence, Healing Our Scars Act. This bill will provide meaningful, comprehensive care to some of Maryland's most vulnerable residents, survivors of domestic violence. Domestic violence leaves wounds that are deeper than the initial injury. Every time a survivor looks in the mirror, scars can trigger vivid memories of violence, causing cycles of anxiety, depression, and post-traumatic stress. The gap in coverage for aesthetic and restorative scar care has forced survivors to carry these burdens, unable to afford the treatment that would allow them to reclaim their sense of self. The Healing Our Scars Act addresses this gap directly by requiring the Maryland Medical Assistance Program to cover aesthetic and restorative services that a physician deems to be medically necessary as a result of injuries caused by domestic violence. Linking coverage to a physician's determination of medical necessity creates a clear, accountable standard that ensures coverage is provided to those who need it, and that care is guided by clinical judgment rather than administrative burdens. Each year, thousands of Marylanders escape abusive situations, and while our healthcare system focuses on treating acute injuries, it too often fails to support survivors in the aftermath. Approximately 34% of women and 28% of men in Maryland are made victims of domestic violence in their lifetime. Depending on the size and placement of the scar, getting a restorative procedure done could cost thousands of dollars out of pocket, leaving victims to choose between whether they should pay exorbitant fees for peace of mind or continue to deal with it due to the prohibitive cost. With the ways in which these scars can cause further mental health complications, there are additional psychiatric costs that could be eliminated by allowing for people to remove these scars. This bill has the ability to save victims money and significantly alleviate victims' pain and mental anguish daily. For too long, we have left our constituents to deal with the lasting effects of domestic violence by themselves. With the Healing Our Scars Act, we have the opportunity to do more for our survivors of domestic violence by recognizing that true healing requires treating the whole person, not just the immediate injury. For these reasons, I strongly urge a favorable report on House Bill 1107.
You have 2 virtual witnesses?
It might just be one. The council in Prince George's is very eager to support, and so it is either Councilmember Fisher, and there might be a Councilmember Adam Stafford as well.
I am seeing Councilmember Fisher on
Yes.
on the television screen. Good afternoon, Councilmember. How are you?
Good afternoon, Madam Vice Chair. It's so lovely to see you and all my former colleagues.
And you may start whenever you're ready.
Thank you. Greetings, Chair Bagnell and Vice Chair Cullison and the members of the Health Committee. My name is Wanika Fisher. I chair the General Assembly Committee on behalf of the Prince George's County Council. We are here to support our strong support for HB 1107, Healing Our Scars Act. This has been a major priority for the County Council, as domestic violence in Prince George's County is one of the leading causes of crime and issues in our community. Domestic violence leaves scars that outlast the danger. Survivors carry these scars and visible injuries in everyday jobs, family gatherings, and interactions. These injuries do not just impact the physical health, but also the mental well-being of our residents and their ability to re-stabilize their lives. Yet under the current Maryland law, insurers and the medical assistance program are not required to cover aesthetic or restorative care needed to treat these injuries. Survivors are left to absorb the cost of this on their own and at the moment that they least can afford it. In Prince George's County, this is not an abstract concern. Our shelters, our service providers, and public safety partners work every day to help. Right now in Prince George's County, non-fatal shootings, domestic, are up 38%. The County Council has invested in housing, legal services, and protection, and we know the firsthand issues around visible physical injuries. HB 1107 will address this gap that real people in our communities are experiencing. This bill closes the gap in a targeted and responsible way. It requires the coverage of medically necessary restorative care as determined by a licensed physician and could directly relate it to the scars and injuries caused by domestic violence. It is narrow and well-scoped standard, and that's simple. If a doctor determines a survivor needs this care, the insurance should cover it. Survivors deserve the full opportunity to heal, not just from immediate danger, but from everything it left behind. The Prince George's County Council, representing over 1 million people here in the state of Maryland, urges a favorable report.
Thank you for your testimony and welcome back to our committee. Are there any questions for this panel from our members? Delegate Tavares.
Thank you. Great bill.
Thank you.
I just want to make sure that I hear you. So, so it was one of the testimonies recommended, including dental. Is vision also on the table? And are we also discussing about therapeutic aid?
So the reason we did not include the dental aspect was because we knew how expensive that would be. We wanted to start with just the scars. I, over the interim, had some really good conversations with our Dr. Delegate on the committee about kind of this world. This is her world of profession. And one of the things that was kind of like an oxymoron was trying to heal a scar, because a scar is already an indication of healing. But we also know that scars can also be reminders of the pain that was initially caused. And so what we wanted to do was focus on restorative care of those scars and leave it to that and try to see if we could get that across the finish line before we added some of these other factors that we know are prevalent within domestic violence situations.
And if I just, yes, ma'am. And just to highlight this issue, I know in reading the testimony of Councilmember Shayla Stafford Adams, she did highlight that we have just in 2025 issued 7,000 peace orders. Is there, just in Prince George's County, is there maybe like an unknown percentage of how many of those might have ended in shelters or even dead?
I'm not sure that information off the top of my head, but I can definitely have my staff do a little bit more research to see if that does exist. One of the things, if you look at the fiscal note, is that the fiscal note indicates that there's very little data that the state has around just domestic violence prevalence. And so that's one of the things why they couldn't pin down what the actual cost of this potentially could be. There's a range. And we also know there's a lot of domestic violence that goes underreported. And so because of those factors, it is somewhat difficult to kind of estimate what is really happening.
Correct. Thank you.
Seeing no further questions, I just wanted to give you an opportunity, Delegate, to respond. There's letters of information from Department of Budget Management and Department of Health. Have you been speaking to them about their concern, because they're concerned about the medically necessary not actually being covered for that some of the impacts of domestic violence might not be covered under medically necessary. So have you spoken to them about how to tailor the bill in such a way to get to your intent?
Yeah, we're still in conversations. You know, it's interesting. I've never gotten a Office of Management and Budget bill, a letter of information for the Health Committee, but I think everyone understands the importance of trying to provide some type of assistance to those that are, you know, victims of domestic violence. How we get there is still under development, but we are in conversation.
Okay, thank you very much. Thank you for your testimony. This does conclude the sponsor panel. We have a favorable we have a favorable with amendment. Michael Patty, if you want to come to the table and give your testimony.
Great. Thank you, Madam Chair. Michael Patty here today on behalf of the Maryland Community Health System Network of Federally Qualified Health Centers and the Maryland Dental Action Coalition in support of the bill with a very small amendment. On the third page, when we talk about a physician, we were just recommending to adopt some language that's more inclusive of other healthcare providers that can make a determination like this. And then in addition to dentistry too, I know that was already a little bit talked about, but I just wanted to highlight how important dentistry is in this space. So we just want to thank Delegate Martinez for continuing to advocate in this space, and we'd ask for a favorable report with that small amendment.
Thank you very much for your testimony. Are there any questions for this witness? Seeing none, thank you very much for your testimony. This concludes the bill hearing on House Bill 1107. We are now going to go to House Bill 1461. This is health insurance coverage for specialty drugs, rheumatology rheumatologic conditions. Delegate Tavares, if you want to approach the table, and you can bring your sponsor panel and begin your testimony when you're ready.
Ay, caramba. Thank you for coming out today. Of course, thank you. All right. Yes, ma'am. Thank you, Chair Carlson and members of the committee. Thank you for the opportunity to present HB 1461. I respectfully ask for your favorable report. This bill improves access to specialty medications for Marylanders living with serious rheumatologic diseases such as rheumatoid arthritis and lupus. And it allows physicians to dispense these medications directly from their medical offices when appropriate. Approximately 1% of Maryland's population, about 60,000 people, suffer from rheumatologic conditions. These diseases disproportionately affect women, particularly women of color, between the ages of 20 and 50, often during their prime working and family building years. When untreated and improperly managed, these conditions can cause severe joint damage, organ complications, loss of mobility, and reduced life expectancy. While many patients respond well to generic medications, roughly 30,000 Marylanders require specialty drug treatments to properly manage their disease. And currently, most specialty drugs are distributed through systems controlled by pharmacy benefit managers, which typically require patients to receive medications through mail order delivery, home drop-off, or designated specialty pharmacies. For many patients, that works really well. But for approximately 10% of patients, about 3,000 Marylanders, this system creates barriers. Some patients live in neighborhoods where package delivery is unreliable or unsafe. Others require closer monitoring when beginning specialty medications. In these cases, patients and physicians often prefer the ability to receive and administer medications directly within the doctor's office. HB 1461 simply provides that flexibility, allowing physicians to dispense specialty medications from their practice ensures patients receive treatment in a medically supervised setting, improves continuity of care, and reduces risks associated with delivery delays, medication loss, or improper self-administration. This bill supports patients, respects physicians' judgment, and ensures that those living with serious rheumatologic diseases can receive the care they need in a setting that works best for them. For these reasons, I respectfully request a favorable report on HB 1461. Thank you for your time and consideration on this matter.
Madam Chair, Madam Vice Chair, I'm Dan Shattuck here today with Arthritis and Rheumatism Associates in support of House Bill 1461. We've been before this committee before on this issue. Committee took a really great step forward last year in passing this bill for oncology, and thank you to Dr. Delegate Johnson and Vice Chair Cullison for making that bill happen. We're here to continue that momentum. There are thousands of Marylanders with lupus, rheumatoid arthritis, and other rheumatologic conditions. This bill before us has no fiscal note. It puts patients first. It will reduce medication waste, and it meets statewide health goals. Specifically, this will prevent flare-ups and reactions that happen when there's missed dosages. When those missed dosages occur, as Delegate Tavares pointed out, that causes flare-ups, it causes joint pain, it sends patients to the emergency room. And right now we're at a point where Maryland is focused on keeping care in the community, keeping care out of the costly hospital setting, and this bill works towards that. This is a step we can take today to help these patients get the care that best suits their needs. This bill allows for patients to accommodate their pharmacy needs to their living conditions, to their circumstances, and does not put their pharmacy care in the hands of a specialty pharmacy that could make them go out of their way, take time off of work, wait in long lines. We'll hear more about that shortly. I wanted you to know that we made available in your testimony packet the testimony. It's been pre-recorded by a young woman who is currently serving a medical mission in Guatemala. She wanted to be here, but she recorded her message. I invite you to listen to that. It's very impactful. And you'll hear more from Dr. Worthing about the patients that he's treating and the circumstances that many have to overcome to maintain the care that they need to keep them healthy, keep them productive, and keep them working. So thank you.
Madam Chair, members of the committee, I'm Dr. Angus Worthing, Arthritis and Rheumatism Associates. I appreciate the opportunity to support the bill today and for your time. As I've said before, in years past, a lot of people with rheumatic diseases who take special drugs get them just fine through the mail at the place they're being steered towards, specialty pharmacies that are mail order. But a few, some, very strongly prefer or need to fill them in our office. And that's because they would like to schedule an injection teaching at the same time to learn how to give themselves a shot, or because they want to avoid all of the delays with weather and safety, et cetera, that Delegate Tavares talked about. When people with rheumatoid arthritis' medicine is delayed, they themselves pay for that with disability in their joints and permanent joint damage if the inflammation lasts long enough. And I would love to have had the oncology community, as Dan mentioned, come today to tell you that the freedoms that you gave them as of January 1st to fill their prescriptions in the oncologist's office are working just fine. Unfortunately, those individuals, I'm told, are not able to access that freedom yet in March this year. So I think it's incumbent on us to give that to more people with rheumatoid arthritis and rheumatic diseases, so that hopefully some of your constituents someday will. We've been dispensing medications for years to people who are protected by Medicare, not to be steered to one pharmacy by their insurer. And we've done it safely and effectively. It's very helpful. So I encourage you to give that freedom to all people with rheumatic diseases in Maryland this year. Thank you very much.
Thank you for your testimony. I'm going to open it up to questions from the members, starting with Delegate Warman.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill. I have lupus and rheumatoid arthritis, and I've experienced this myself. So this question is for the doctor. Can you just tell me how patients are being negatively impacted? Because I wish I could tell my committee members how people are really negatively impacted by the current law. Thank you.
That's a fantastic question, and I very much appreciate your personal experience and that question. I would refer you to the outstanding testimony that you have, or video testimony that you have, following the QR code that Dan mentioned. I'll also bring up one other patient who was unable to be here today. The drug that she was taking for her autoimmune disease is having a very large impact on her joints of her hands, make it difficult to work, was working just fine, and she was obtaining that in our pharmacy in the office, where she preferred to get it. And then she was steered by her insurance company to their specialty pharmacy and required to get it through the mail. And during that period of time, she and I decided together to reduce the dose for other reasons related to her specific care. Unfortunately, after my office got a prior authorization and coverage determination for the change in dose, less medication, and I sent that prescription to that pharmacy and it was received, and the patient asked for it to be delivered, they sent the wrong dose. And the patient had flare for arthritis. And when they send an amount of medication for a month, she's committed to take that for that month. Seeing this preventable problem, I don't know if this was just a simple mistake or something that happened, as somebody's personal physician who sees this person on a regular basis for years, knows their arthritis, knows the dose that they need, and who scans and dispenses all of the prescriptions in the pharmacy, that was a really unfortunate moment when she came back to me the next visit. So something that can be totally preventable for, like we said, a small proportion of people who would prefer or need to get their prescriptions through our office. And really appreciate your interest and your question. Thanks.
Delegate Johnson.
Thank you, Madam Chair. Thank you, Delegate, for bringing the bill. Doctor, can you tell us a little bit about the process and the time frame when a medication somehow doesn't get delivered, gets lost or damaged in the mail?
Can you be more specific, the time frame of?
Time frame of how long it takes working with you and the insurance companies then to get their medication that was ordered in the first place?
Sure, that's a great question. I appreciate your question. So usually prescriptions will be sent on a monthly basis for specialty drugs because of the high cost. And I guess we've heard earlier today about trying to provide a year at a time or several months at a time. Having a life-changing medication come once a month can be pretty stressful for people. And so it is probably on a weekly or twice a week basis that a problem comes to me after being addressed by my staff, et cetera, where something like that happened, a delay, a coverage change, a medicine being shipped incorrectly or not arriving on time or not arriving, period. And so, like I said in the previous question, usually that cancels the month. So the month is done, they have to wait until the next month because the shipment already went out the pharmacy and the insurance already paid for it. Sometimes we might be able to have, if it's still a branded and sampled drug, we might have a sample for a week or two of medication that we can have the patient come in and we can dispense that to them. But and occasionally they might get a second shipment that month before waiting the whole month. But usually once that mistake is made, it's a month-long mistake.
Thank you. Thank you, Madam Chair.
Thank you.
Vice Chair Cullison.
You referenced what I heard was kind of a dispensing of Medicare drugs. So can you talk to us about how that works, where you purchase them from or, how that process is working for you?
Sure. What I'm talking about the Medicare Part D prescription drug plans.
Right.
So I don't have to tell this body about that plan, but in prescribing a medication to a patient, if they're commercially insured, right now that person gets steered in Maryland to a specialty pharmacy. But if they have Medicare Part D coverage, that person can fill that prescription at any pharmacy. And so I might be that pharmacy if they prefer that. I'd say probably a fifth, maybe a tenth of people prefer to get it at their appointment or at our office, or we have a courier system where we can send it to them. And many of the rest are actually de facto steered to the prescription drug plans specialty pharmacy. And I get those drugs on the marketplace the way I get any drug, sort of like a pharmacy would. And I'm acting as the pharmacist, keeping those drugs safe and in inventory and specifically for the patient who's coming in to get it. I'll say this is very similar to specialty drugs that we've been administering in injection or infusion for decades in infusion centers and injection centers. And so we have a familiarity, and we have a staff that handles this very well on the business side and nurses, et cetera. So we, I think, do an excellent job and have all of the information on the medical record of the patient right there at the clinic in order to provide that quality service. Does that answer your question?
Yes, thank you. Thank you, Madam
Thanks.
Chair.
And appreciate your reaching out. I'll tell Evan.
Seeing no further questions, this concludes this panel. We do have an unfavorable panel. So if I can bring Matthew Celentano and Kimberly Robinson to the table, and you can give us your testimony.
Madam Chair, members of the committee, Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to House Bill 1461. This bill is essentially an amendment that was offered and rejected to House Bill 1243 that this body did pass last year. The existing statute was crafted with oncology in mind, where office-based administration of specialty drugs is clinically integrated with treatment monitoring. Rheumatology and rheumatologic conditions, while serious and chronic, present a different clinical picture. Many rheumatology specialty drugs, like self-injectable biologics, are routinely and safely dispensed by mail order or specialty pharmacy with no clinical compromise. This bill does not establish that in-office dispensing for rheumatology produces materially better patient outcomes sufficient to justify the potential added cost mandate. The key difference in this year's legislation and the bill that became effective less than 3 months ago is that hopefully cancer treatments do end. A condition treated by a rheumatologist could continue for the rest of your life. This body took many, many years to become comfortable with moving forward with the oncology dispensing bill that passed last year. And we spoke many times through the process about seeing the impact over time before we move forward with an expansion. We suggest we let that time happen, and we can return to address this legislation in the future with the benefit of experience. For those reasons, we ask for an unfavorable report on House Bill 1461.
Thank you, Madam Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield, respectfully in opposition to the bill. Trying to build on and not necessarily repeat things that Mr. Celentano just shared with you. I will address one of the things that we heard in the proponent's testimony about what the experience has been from a timeline from the oncology side, interestingly enough, because it was referenced. The bill that you passed last year took effect January 1, 2026. I think that's about 72 days ago so far. And like most insurance bills, it applies to contracts issued or renewed after that date. So people whose contracts started January 1, that is in fact the way their drug benefit is now framed. If you are on a July 1 contract or an October 1 contract, very, very common other dates, those contracts haven't caught up yet, right? So it is a little bit of a rolling implementation, and so we don't have a lot of experience on the oncology side as of yet. In addition, as I've said a couple of times this year in this committee, to all of our frustration in one way or another, the bills you pass only hit 17% of Marylanders. And so I also want to just level set for the committee and for any of the providers who are listening, even on the oncology side, what Maryland passed is not going to hit every person who comes in their door. And that would be the same here for rheumatology. So that's just a perspective on even what the bill can possibly do. Right now, I think our biggest concerns is the time frame. We are still getting up and running on the oncology side, understanding what the implications and the impact of that has been. And one of the other things that our clinical team did raise was some questions just in looking at rheumatology drugs and oncology drugs as being all the same or one-to-one, that there are a different scope in terms of that support that needs to happen in office around the oncology drugs. There are some certainly on the rheumatology side, but taking exactly the same language gave them some heartburn, and so we think there's further conversation to be had even as the law is expanded. And with that, we urge in this moment your unfavorable report.
Thank you for your testimony. Are there any questions for this panel from the members? Seeing none, thank you very much for your testimony. This concludes the bill hearing on House Bill 1461. At the request of our youngest member of the Health Committee, we're actually going to move to House Bill 1118, which is health insurance and health occupations, perinatal mental health conditions. Delegate White Holland, if you want to bring your panel and you can begin your testimony. And we welcome baby Riley back to our committee, not to be confused with.
And I do have a virtual witness, Dr. Rhoda Talawi.
Yes, I have, yep, and we have, she's not in the lobby? Okay, she's.
Dr. Polsky, where did he go? We'll call you up later.
Delegate White Holland, she's not in the lobby.
But we'll ask Dr. Polsky to come forward then.
Okay.
Thank you so much.
Thank you very much, and you can begin your testimony when you're ready.
Okay. All right, well, good afternoon, Madam Chair and fellow members of the House Health Committee. For the record, I'm Delegate Jennifer White Holland with my deputy delegate here, and I appreciate the opportunity to present HB 1118, Health Insurance and Health Occupations, Perinatal Mental Health Conditions for your consideration. After our deputy delegate, Riley, was born, and prior to discharge, I received this red wristband that reads, "I gave birth, still at risk." Last session and throughout my pregnancy, I experienced hypertension and ultimately preeclampsia and went through a lot to get this little one here. While I may not wear this band as frequently as I did early in my postpartum journey, I keep it nearby and continue to reflect on the words "still at risk" and the risk mamas like me and across Maryland face related to our physical and especially our mental health. I came home overjoyed and in awe of Riley. I basked in the joys, and I also endured a lot mentally and emotionally, coming home to such newness, having to balance and do so much. I was also grateful, though, to have access to a perinatal mental health provider who I could speak to and joined a virtual mommy group paired with my Centering Pregnancy tribe, where I was able to be affirmed in my feelings and I knew I wasn't alone. Even past the first 6 weeks, mamas are still at risk. 43 days up to a year postpartum, still at risk. Based on data from the MD Mom Task Force, the leading causes of all pregnancy-associated deaths were behavioral health conditions. As you have heard in the latest briefing, we're not doing well in our state. And so before you today is a bill that builds upon our work that this body has done to address this maternal health crisis. This bill seeks to increase access to screening, provider training for perinatal mental health, and patient education to combat the persistent disparities we see around maternal morbidity and mortality in our state. I would, of course, like to express my sincerest gratitude to our work group that came together last year to strengthen perinatal health for mamas and their families across the state. This bill, in both its introductory and amended posture, reflects countless one-on-one discussions and group discussions over the last several months and weeks with a diverse range of voices, including OBGYNs, pediatricians, nurses, midwives, mamas, doulas, carriers, the Maryland Department of Health, the Maryland Healthcare Commission, Department of Budget and Management, the Board of Nursing, the Board of Physicians, the Maryland Insurance Administration, perinatal mental health providers, mental health advocacy organizations, our Maryland Association of County Health Officers, family members, and advocates. In my remaining time, I would like to walk you through the amendments that have been made after weeks of discussion. And the amendments and the reprint were also previously shared with each of you, so I encourage you to follow along. And I would like to, again, elevate that this is a legislative priority for the Legislative Black Caucus of Maryland, and it is important to note that these and other amendments that I will discuss address the fiscal note completely. Allow me to walk you through these amendments. The inclusion of Medicaid. On page 2 of the reprint in the health article, This amendment incorporates additional screenings to the Medicaid program, which is a covered benefit as outlined in the Maryland Department of Health's testimony. The additional screenings will be at prenatal visits within the first 6 weeks postpartum and at each well baby visits, which are at months 1, 2, 4, 6, 9, and 12, which begins in 2027. Please note that in our work group, while screening at every prenatal visit is ideal, we came to consensus and agreed that it would be better to do this screening once per trimester to ensure the provider can manage other potential health needs that need to be managed during these visits. Plus, this aligns with the American College of Obstetricians and Gynecologists, or ACOG, recommendations. This change will be reflected in other parts of the bill where it remains. Definitions. On page 3 of the reprint, we update the term of perinatal mental health conditions to reflect perinatal behavioral health conditions, which is a more inclusive term to capture mental health and substance use disorder conditions. Insurance articles as it relates to standing referrals. On page 4 of the reprint, we update language to standing referrals to ensure that patients are connected to licensed behavioral health providers and clarify that these referrals be made available over the course of pregnancy and up to 1 year after the conclusion of pregnancy. Given the concerns elevated by the Department Budget Management related to out-of-network providers, we decided to address their concern, and so I accept their friendly amendment to add language that limits out-of-network referrals to situations where a carrier cannot provide access to an in-network behavioral health provider within the appointment wait time and travel distance standards already established in regulation. Council was made aware, and we are prepared to incorporate this language, which also addresses one aspect of the fiscal note. Insurance article as it relates to our state employees insurance plan and commercial insurance. On page 6 of the reprint, we strike language related to the screenings for prenatal visits and within 6 weeks postpartum. However, we codify existing practice by keeping screenings at each well child visit within the first 6 months of the child's life. These screenings, of which Riley has completed 4 of these visits, are a part of the state's Healthy Kids EPSDT program, which promotes access to and ensures availability of quality health care for medical assistance children, teens, and young adults less than 21 years of age. By removing these additional screenings, it addresses another issue elevated by the carriers and Department of Budget Management, which speaks to the remaining concerns in the fiscal note. Provider education and health occupation article. On page 9 of the reprint, after conversation with the Board of Physicians, we decided to strike language in section 20-1804, lines 13 to 17, to position the Department of Health to be responsible for providing a list of training programs on request, not in consultation with the Board of Nursing or Board of Physicians. And on page 10 of the reprint, we strike language through section 1-231 of the health occupations article and add language proposed by the Board of Nursing and affirmed by the Board of Physicians related to provider training and how continuing education units would be counted. Finally, in section 3 of the bill, thank you, Riley, on page 10 of the reprint, a study is included to be conducted by the Maryland Healthcare Commission that will conduct an analysis related to added screenings. After having discussions with the Maryland Healthcare Commission, they affirmed their capacity to complete these analyses as outlined in the bill. Again, concerning the fiscal note, we have taken language presented by the Department of Budget Management and the carriers in the reprint that removes language related to additional screenings during prenatal visits within 6 weeks postpartum and well child visits for commercial carriers and the state employees plan. Additionally, the Department of Budget and Management elevated a concern with the cost-sharing prohibition as it relates to high-deductible health plans with health savings accounts. Because we reference and explicitly tie the screening benefit to the U.S. Preventative Task Force guidelines, this helps to protect the HSA pre-tax status for high-deductible health plan enrollees. We are aware of the amendments being brought forth by the American College of Nurse Midwives. The first amendment was previously addressed in my testimony regarding the frequency of screenings during the perinatal period. The second amendment related to the sharing of patient resources. This amendment is considered friendly and would like to accept it as a sponsor amendment. Colleagues, as you have heard, we have worked diligently over the last several months. Even baby Riley was put to work in virtual calls late last year. All of our issues have been addressed, as you will hear in our testimony, and I am proud to say that the fiscal note has been addressed as amended through our collaboration and ongoing discussions with our work group. As mamas continue to receive this wristband that I just showed you all, as a reminder to themselves and others they may encounter, by passing this bill, we will be able to prevent severe complications and better support mamas going through pregnancy or postpartum. I will, bless you. I will kindly ask my panel to share their stories and testimony. Colleagues, I am humbly asked for a favorable report. Thank you for your consideration.
Good afternoon, committee members, and thank you for your time and consideration with this bill. My name is Kristen Brooks, and I'm a licensed clinical social worker and the founder of Building Beyond Therapy, a group therapy practice based in Prince George's County. I'm a perinatal mental health certified clinician, a member of the Maryland Black Perinatal Health and Reproductive Justice Collective, and a survivor of perinatal mood and anxiety disorders. I'm here today in favor of HB 1118. I was driven toward this work after my own experience with postpartum depression and anxiety almost 10 years ago, which I unfortunately navigated untreated. Despite my training as a social worker, I was unaware of what was happening to me, as at the time I lacked the specialized training necessary to identify perinatal mood disorders. I just knew I was not okay. As a clinician, I encounter birthing individuals on a daily basis that are suffering. Many are not having the postpartum experiences they expected and often feel guilty for admitting so. I see mothers that have experienced trauma related to pregnancy, birth, perinatal loss, and fertility concerns, but were not screened and properly identified as needing professional assistance. Therefore, their path to my practice took much longer than necessary. I hear from physicians and other practitioners the desire to help their patients, but lack the evidence-based training to properly identify warning signs and the referral networks to do so. This bill would move Maryland in the right direction. Providers that support perinatal individuals would be properly trained and feel more empowered to screen and refer, thus leading to families receiving proper care and no longer suffering in silence. I respectfully ask that this committee advance this bill to show birthing individuals and their families that their mental health at the most vulnerable time in their lives is a priority. Thank you for your time and commitment to perinatal mental health, and I respectfully request a favorable outcome of this bill. Thank you.
Madam Chair, Madam Vice Chair, members of the committee, my name is Larry Polsky. I'm here on behalf of the Maryland Association of County Health Officers in support of HB 1118 with sponsor amendments. The most recent Maryland maternal mortality report documented that behavioral health conditions are responsible for over 3 times more deaths than the next leading cause. In addition, according to the 2025 Maryland Maternal Health Innovation Report, 40% of women with severe pregnancy or postpartum complications had underlying mental health and/or substance use conditions. This is more than any other contributing factor, including obesity and hypertension. Because of the rapid hormonal and other physiological changes that take place during pregnancy and postpartum, health problems can accelerate at a greater pace than in other times in people's lives. As a result, repeating mental health and substance use screenings during each trimester and again at intervals in the first year after pregnancy is critical to ensuring that conditions will be diagnosed at a point when medical and social support interventions can prevent dire consequences, such as suicide attempts, overdoses, or harm to an infant as a result of unintended neglect. 2 of the main recommendations from the Maryland Maternal Health Innovation Program are 1, to enhance screenings and medical therapies for behavioral health conditions, including substance use disorders, depression, and anxiety, and 2, increase pregnancy and postpartum referrals and connections to services. HB 1118 will codify advancements toward these goals. We thank Delegate White-Holland for working with stakeholders to craft this bill into legislation that can greatly improve the health and safety of pregnant and postpartum women and their children. On behalf of the Maryland Association of County Health Officers, I respectfully request a favorable report.
Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland, here in strong support of House Bill 1118. And I just want to say this is one of my favorite bills this session. I'm really excited to testify in favor. This is a bill that's well past due, and it's going to have a tremendous impact on Marylanders. Postpartum depression is the #1 obstetric complication in the United States. And although this and other perinatal mental health conditions are treatable once recognized, 75% of them are never identified. And you'll hear more about these from the panelists coming up later. But, the stat led the General Assembly back in 2015. I'm sitting here in this committee, and legislation that kind of originated in this committee, and several of you were co-sponsors of that bill back in 2015 to create the task force to study maternal mental health. And that group issued a report a year later with really comprehensive, really wonderful recommendations, and some of those were addressed, but some of the more impactful ones were never enacted. And that's where this bill steps in and kind of carries on that work and would implement some of those more impactful recommendations from that 2016 report. And so I'm so thankful to Delegate White-Holland for making this a priority, and in the grand HCO tradition and now health tradition of bringing all the stakeholders together and hashing out all the differences ahead of time and getting this ready for the hearing. I think the bill's in a wonderful posture with the sponsor amendments. I just know this will have a hugely positive impact for Maryland mothers and their families. Couldn't be happier to support. And I just also want to say the Maryland Children's Behavioral Health Coalition, this is a priority piece of legislation for that coalition, which is a coalition of consumer and family advocacy groups, peer-led organizations, provider associations, professional associations, health systems, and more. And so, again, really excited about this. Great bill, and please support House Bill 1118. Thank you. Yep.
Good afternoon, Chair Bagnall and members of the House Health Committee. My name is Kyra Vachi. I'm here today as a maternal mental health advocate, as the founder of Andrea's Wish Foundation, and as a representative of Postpartum Support International Maryland chapter. We are in strong support of House Bill 1118. I'm also here because of my sister, Andrea. Brought her along with me. Andrea gave birth to her beautiful son, Harbor, on August 24th, 2023, and like so many mothers, she struggled silently in months that followed. She loved her baby deeply, she wanted to be well, but she fell through the cracks of a healthcare system that screens without always ensuring connection to care. I know. She was identified as struggling, but there was no clear urgent pathway, no coordinated follow-up, no rapid response. And 3 months after giving birth, Andrea died by suicide, one day after her 35th birthday on December 11th, 2023. Our family lives every day with the reality that her death may have been preventable if there had been stronger systems in place, if a positive screen had triggered immediate action, clear referrals, and real follow-up. Postpartum depression and psychosis are treatable. This is why this bill matters so deeply to me. Expanding screening, strengthening insurance coverage, and requiring provider education are critical and long overdue. But I urge you to ensure that screening does not become a checkbox. When a mother screens positive, that must trigger action. We need a standardized care activation process and a required response protocol so providers know exactly what to do next. Referrals must happen quickly. Access to trained specialists must be timely. Care coordination and follow-up must be built into the process so families are not left to navigate it all alone. Because when a mother finally says, "I'm not okay," delays can be dangerous. In the postpartum period, weeks matter, sometimes days matter. Andrea's story is not rare, and that is exactly the problem. I cannot change what happened to my sister, but together we can change what happens next for Maryland mothers. So on behalf of PSI, Maryland chapter, and in honor of Andrea and her son Harbor, I'm asking you from the deepest place in my heart to strengthen this bill so that another family is spared the pain of a preventable tragedy that mine carries every single day. And I wanted to thank you, Delegate White-Holland, for her dedication, her time, and her leadership. Thank you.
Thank you for your testimony, and we're truly sorry for your loss.
Thank you.
I'm going to open it up for questions from the members, and I will just say, I'm not allowed to have a favorite bill, but if I did, strong contender. Are there any questions from our members? Seeing none, I also just want to thank you for all of your work on this, and I think this demonstrates why I go to bat anytime somebody questions the integrity of the work of this committee. This concludes this panel. We do have a favorable panel and a favorable with amendments. So if we can bring Anna Rodney, Madeline Del Greco, Micah Goldberg, and Michael Tran. Oh, you're right. You can begin when you're ready.
Good afternoon, Chair, Vice Chair, members of the committee. My name is Madeline Del Greco with the Maryland Board of Physicians, here today in support of House Bill 1118, Health Insurance, and Health Occupations, Perinatal Mental Health Conditions. First, the board would like to thank Delegate White-Holland for her attention to perinatal mental health, listening to the board's initial operational concerns, and for her commitment to collaboration. Appreciate being part of the conversation. The board was involved in drafting amendments that would, among other changes, incentivize the perinatal mental health training by authorizing the board to recognize 1 training hour as 2 continuing education credits, and this approach is operationally workable for the board. We appreciate being given the opportunity to work collaboratively with the delegate on House Bill 1118 and to ensure operational feasibility while maintaining the intent of the legislation. Thank you.
Good afternoon, Chair and members of the committee. I first want to say thank you to Delegate White-Holland for all of her tireless work. When my first child was born prematurely, doctors told me he might not make it through the night. I was lying in a hospital bed after emergency surgery, terrified, exhausted, and in shock, and yet no one screened me. No one assessed my mental health in the midst of the most traumatic event of my life. I had to ask for help myself. That meant I had to detach from my own pain enough to calmly request a therapist. And when I did, I was asked the question that stunned me. Are you having thoughts of killing yourself? And because I was not actively suicidal, my request for help was not treated as urgent. As a Black woman, I am acutely aware of the narrow space we often are allowed to occupy in moments like this. If we remain calm, our pain can be minimized. If we show distress, we risk being labeled dramatic or drug-seeking. Either way, the burden too often falls on us to prove we deserve care. My name is Anna Rodney, and I serve as the Director of Advocacy and Public Policy for the Dual Alliance of Maryland, President of Maryland Families for Safe Birth, and Systems Change and Policy Committee Chair for March of Dimes. I'm also the mother of 2 children, one who is asleep with me right now. The next morning, a social worker was assigned to me for my first son's condition, not because I requested mental health care. I had to again advocate before I was finally screened and referred to support. The screening revealed I was experiencing adjustment disorder, depression, and post-traumatic stress disorder. These were very serious mental health conditions that were nearly overlooked, not because they weren't present, but because no one had taken the step to screen me. This is why House Bill 1118 matters. Perinatal mental health conditions affect 1 in 5 women, yet 75% never receive treatment. And they are the leading cause of maternal death, accounting for approximately 22% of maternal death. House Bill 1118 would require screenings for perinatal mental health conditions, strengthen provider education, and help build a more coordinated statewide system of care. Right now, Maryland receives an F for gaps for perinatal postpartum screening and accountability related to maternal mental health. Screening should not depend on whether someone asks the right way, has the energy to advocate, or has the knowledge to recognize what they are experiencing. Maternal mental health is maternal health. For these reasons, I respectfully urge a favorable point on House Bill 1118. Thank you very much.
Thank you for your testimony and for sharing your story.
Sorry. Good afternoon, Madam Chair, Madam Vice Chair, and committee members. For the record, Michael Tran with the Maryland Board of Physicians, and here of support for HB 1118. I'm a Me Too, Delegate White-Holland. Thank you. She got us all of these wonderful stakeholders at the table in the interim, and kind of posed a question, asked us how we best should solve this. And through the summer, through the work, and we all got it done. And the bill is in a good posture, and we are here in support. Thank you.
Hi, Madam Chair and members of the Health Committee. Thank you for the opportunity to testify. My name is Mika Goldman-Berg, and I'm here in support of House Bill 1118. I also want to commend Delegate White-Holland for her stewardship and steadfastness in sponsoring this bill. I serve as the Assistant Director of the Postpartum Support International Chapters Program. I'm a policy fellow with the Policy Center for Maternal Mental Health and a member of both the PSI Maryland and Chamber of Mothers chapters. But today, I'm here first and foremost as a mother who personally fell through the gaps in our healthcare system. I am fortunate to be here today at all. Thankfully, my family could afford out-of-pocket expenses for specialized perinatal mental health care in addition to our insurance plan. Without that access, my story would have ended very differently. Still, even with access to the best possible care, I encountered alarming gaps. I was shamed by providers for prioritizing taking life-saving medication over breastfeeding. One nurse informed me of my alarmingly high screening score, yet walked out of the room without referrals or follow-up. Another provider told me perinatal mental health conditions were quote unquote made up and advised me to stop my medication. This kind of misinformation is dangerous, and it underscores why provider training is critical. Perinatal mental health conditions affect 1 in 5 moms, and they're a leading contributor to maternal mortality in Maryland. When untreated or not properly treated, these conditions can have devastating consequences for mothers, children, families, and communities. House Bill 1118 takes important and meaningful steps to strengthen Maryland's response. The items in these bills are not new. They are recommendations from the 2015 Task Force report. It is time to act. Maryland mothers, Maryland families have waited long enough. This bill may not solve every gap this year, but it represents real progress. I look forward to continuing to work with the General Assembly, the MHCC, MDH, and the broad coalition of stakeholders that shape this bill to make that a reality. I respectfully urge a favorable report. Thank you.
Thank you for your testimony. Are there any questions from the members for this panel? Seeing none, thank you very much for being here today and for sharing your stories. And we understand that these are not made up. That's bugging me. We have one more favorable panel and then a favorable with amendments. So I've got Pilar Olivo, Marika Toscano, and virtually Lauren Thompson. If you want to come to the table and you can give us your testimony.
Thank you, Madam Chair and committee members. My name is Pilar Olivo, and I serve as Executive Project Manager of Family Connects Frederick County, and I'm here in support of HB 1118. Family Connects Frederick County, operated by Frederick Health Hospital, offers all Frederick County families with newborns a visit at home with a nurse at no charge. All our staff have been trained by PSI, and 7 out of 12 nurses are certified in perinatal mental health. Our nurses visited almost 4,000 families with newborns over 3 years. Our independent evaluator recently conducted surveys among 2,000 Frederick County families with newborns. 72% of respondents to the survey experienced worry, doubt, hopelessness, or sadness within the first 12 weeks of giving birth. How are we able to support families? Through training, screening, and quality referrals. The nurse visits the family when the newborn is about 3 weeks old, bridging a gap in standard care for newborns and for mothers. The nurse does a comprehensive assessment, including depression and anxiety screening. We connect caregivers and their partners, if needed, to resources that match the family's needs and insurance. On top of staff training, we invested in 20 stipends for local birth workers and mental health providers. Trainees have shared their effectiveness. My client began to panic frequently about her new baby not being okay, becoming tearful that she was not a good mother. She got into her doctor and is now doing great. With a mother experiencing postpartum paranoia, I was able to recognize, openly discuss, and connect to resources to support mother and keep baby safe. We've been able to help our immigrant community. I was better able to advise a client that medication was an acceptable route during the 3rd trimester. 88% of families who participated in one of our nurse visits had their experience of worry, doubt, hopelessness, sadness addressed. And that is 18% more, statistically significant, more than non-participants. I'm in support of the bill. Thank you.
Madam Chair, Madam Vice Chair, and members of the committee, my name is Marika Toscano. I'm a maternal fetal medicine physician at Johns Hopkins University, and I also lead our perinatal integrated health clinic there. And I'm here today to support House Bill 1118. Perinatal mental health conditions, including postpartum depression and anxiety, are among the most common complications of pregnancy, but they are under-recognized and undertreated. In my clinical practice, I often meet patients who come in for their routine prenatal visits or for ultrasounds, and they disclose symptoms of depression and anxiety that they have been experiencing for weeks or months. There are also those who don't feel comfortable disclosing and are white knuckling it through their pregnancy or postpartum period, and screening would be a way to capture these individuals that are going unnoticed. Without these structured screening and clear referral pathways, these concerns are easily missed. This bill helps address that gap by ensuring routine screening for perinatal mental health conditions. I've been involved in efforts to integrate depression screening systematically into postpartum and prenatal care in our health system, and I've seen that when screening becomes part of routine workflow, we can identify more patients who need support, and we can connect them with care earlier. This legislation would help extend these kinds of evidence-based screening practices across Maryland. And this bill also helps to improve access to care, and it strengthens clinician education. Having been through an OBGYN residency and a maternal fetal medicine fellowship, and also studied the resources used by trainees in OBGYN, there is limited guidance on recognizing and managing mood and anxiety disorders in pregnancy, and continuing education requirements through this bill can help ensure that clinicians are better prepared to identify and support patients experiencing these conditions. For these reasons, I respectfully urge a favorable report on House Bill 1118. It has the potential to improve maternal health outcomes and prevent avoidable tragedies for families across Maryland. Thank you for your time.
Thank you for your testimony. Lauren Thompson, if you can unmute and begin your testimony.
Can you hear me okay?
Yes, we can.
Okay, great. Good afternoon, Chair Bagnall and members of the House Health Committee. My name is Lauren Thompson, and I come to you as a doula, lactation counselor, mental health advocate, mother of 3, and co-founder of Anne Arundel-based nonprofit called Community After Birth. I also come to you from my first girls' trip in 4 years from the mountains of North Carolina, so this was too important to miss. I'm here to request a favorable vote from you on House Bill 1118. Community After Birth serves parents and their babies right here in Annapolis and across the county. Its mission is simple: to improve postpartum care and support. Our small team has been providing postpartum doula support at no cost to military members and their spouses, in addition to those under the care of a mental health provider. Our eligible spaces always fill, and local mental health providers report positive feedback and refer confidently to our program. The program and doula team have become beloved by parents who receive this life-saving support. To give you a better idea of our model and finances, our small nonprofit was given $25,000 to pilot this county-based doula program for 15 families. This was a generous donation from Kyra, who was on a previous panel, who I met through our work and shared mission at PSI Maryland. We're able to fund our part-time doula team insurance costs and operating fees. We have no paid staff to support administrative billing, screening, or filing taxes. Even though we're limited on funds and resources, our team still manages to screen because we know it saves lives and it's simple to implement. If a parent screens at risk, they are immediately followed up with, and additional resources and referrals are offered. This process is automated into our intake system. It takes 10 minutes or less for a parent to fill out the form and 10 minutes or less for us to score the form manually. Our team is currently not eligible for public or commercial reimbursement for this. Untreated PMH disorders create a gaping hole in our state's economy. Our state and local economies hemorrhage money through reactionary care and perinatal misses. Investing in screening can alleviate costs related to death, morbidity, infant development, child and adult disability, K-12 education, and public safety and correctional services. Perinatal mental health is both a health issue and a fiscal issue. Passage of this bill is a great first step in the right direction for Marylanders. Thank you for listening and considering a favorable vote on House Bill 1118.
Thank you for your testimony. I got to say, babies and mountain views. Delegate White Holland has really raised the bar. Are there any questions for this panel from the members? Seeing none, thank you all very much for your testimony. We do have one favorable with amendments panel. So if I can bring Sarah Case Heron, Allison Taylor, Robin Elliott, Christine Crone, and Natasha Mayhew to the table, and you can begin your testimony when you're ready.
Yeah, Allison Taylor is not able to join, but I understand she echoes what I'm about to say. So, then It's okay, I'll go first. Good afternoon, Chair Bagnall, Vice Chair Collison, and members of the Health Committee. My name is Sarah Case Herron, and I am here today representing the League of Life and Health Insurers of Maryland. The League supports House Bill 1118, Health Insurance and Health Occupations Perinatal Mental Health Condition, with the sponsors' amendments that she detailed previously. We really recognize the importance of perinatal behavioral health care for Maryland mothers and are really grateful that this bill is moving things forward, and grateful for all of the work that Delegate White-Holland has done with us and our colleagues, also including the work that little baby Riley has also contributed as well. So we really thank her for meeting with us and helping to address our concerns, and as a result, we urge a favorable report with the sponsor amendments for House Bill 1118.
Good afternoon, Madam Chair, Vice Chair, members of the committee. Natasha Mayo here on behalf of the Maryland Hospital Association, support with amendments to House Bill 1118. Perinatal behavioral health conditions affect thousands of Maryland families each year, and untreated behavioral health conditions are linked to higher rates of poor maternal and infant outcomes. Addressing them early is a critical component of improving maternal health in Maryland. Hospitals support strengthening the continuum of care so patients are identified earlier and connected to treatment before crisis occurs. As you've heard, this bill moves that work forward by establishing a clear and comprehensive definition of perinatal behavioral health conditions, recognizing that both mental health and substance use disorders require attention. The bill creates a standing referral to a licensed behavioral health provider, helping patients move from screening to actual care without unnecessary delays. It really helps close the gap between identification and clinically necessary treatment, a gap which patients often fall through the cracks. The legislation also supports provider education and patient awareness, giving clinicians better tools and helping families understand when and how to seek care. Maryland has made progress on maternal health in recent years, but behavioral health remains a leading driver of pregnancy-associated deaths. So this bill is really a logical step forward for strengthening care in this area. We appreciate the sponsors' collaborative approach on amendments developed through feedback from the stakeholders to refine the bill while supporting workable implementation. We look forward to continuing to sit at the table and contributing to the work to strengthen perinatal behavioral health in Maryland. So with that, we urge a favorable with amendments report on the bill.
Good afternoon, Robin Elliott here on behalf of the American College of Nurse Midwives. Just two notes. I've noticed, I think everybody who's testifying has thanked the sponsor for her very collaborative approach and also for baby Riley. So just this is a hallmark of this committee and your members, and want to thank you all for it. And lastly, just want to thank you for being here past 5 o'clock and wishing you all maybe in about 30 days your own vacation in North Carolina or whatever destination you choose. Thank you.
Good afternoon, members of the Health Committee, Chair Cullison, Chair Bagnall, Vice Chair Cullison, and members of the Health Committee. My name is Christine Crone, here on behalf of the physicians, specifically MedChi, the Maryland State Medical Society, the Maryland chapter of the American Academy of Pediatrics, and the Maryland section of the American College of Obstetricians and Gynecologists. And with the sponsors' amendments noted, we urge a favorable report. Thank you.
Thank you very much for your testimony. Are there any questions for this panel from the members? Seeing none, thank you very much for your testimony. This does conclude the hearing on House Bill 1118, and we're going to go to our last bill of the day. This is House Bill 1117, Elopement Response Devices Insurance and Maryland Medical Assistance Program Coverage and Provision under State Programs. Delegate Lopez, if you want to go ahead and head to the table, and you can bring your sponsor panel, and you can get started with your testimony when you're ready.
You guys are champions, warriors.
Thank you
for making it this far. Okay, here we go.
I know, here we go.
All right. Good evening, Madam Chair, Madam Vice Chair, members of the committee. I'm proud to be before you today to sponsor your last bill on a Friday. Look alive, everybody. My name is Delegate Leslie Lopez. I'm proud to represent District 39 and to be here to ask for your favorable support. I want to share with you a story about a constituent. 2 years ago, the Hall family from my district reached out and told me about their son named Rashawn. Rashawn lives with autism and Down syndrome. One day, he wandered away from his caregivers. What followed was every parent's nightmare. Rashawn went missing for 6 days. 6 days of searching, 6 days of fearing the worst, 6 days of hoping for a miracle. And thankfully, Rashawn was found. But unfortunately, it was horrible news. He had been locked inside a Metro storage room in DC, like a closet, after somehow taking buses and Metro trains from Montgomery County into the district. Until hearing Rashawn's story, I didn't really have a full appreciation of the term elopement. In the disability community, it is very well known, however. Elopement, often called wandering, occurs when a person leaves a safe area or caregiver supervision and becomes lost or disoriented. It is very, very common. I bet every single person in this room has had a constituent, either a child with autism or a senior with Alzheimer's or dementia who's wandered away, and you've heard the silver alerts and everything like that. This behavior is particularly common among individuals with autism and those living with Alzheimer's disease or related dementias. For family members, this means living with the ambient anxiety that an elopement event can happen at any moment, even within seconds, and even under close supervision. Rashawn's father has submitted written testimony today, and I encourage the committee to read it and fully absorb what the Hall family has endured. The truth is, Rashawn's story is not unique at all. The Centers for Disease Control and Prevention report that half of children with autism have wandered from a safe environment at some point. The individuals living with Alzheimer's disease or related dementias, the number is even higher. And when someone wanders, the risks are immediate and severe, from traffic accidents, increased exposure to injury, and tragically and very commonly drowning. Families often describe these moments as a race against the clock, where every single second matters. HB 1117 provides a simple, practical solution. It ensures that when a doctor determines someone is at risk for elopement, families can access GPS-enabled response devices through their health insurance or the Maryland Medical Assistance Program. These devices allow caregivers and first responders to quickly locate someone who has wandered away. This bill helps the first responders who drop everything to find a missing child or a vulnerable adult. When responders know where to look, searches become faster, safer, and more effective. And I know we got a fiscal note very late about this. I think just within an hour or so of these hearings beginning, we received a fiscal note. And it looks very similar to fiscal notes with insurance mandates. But I will say, what the fiscal note does not include is the offsets of savings that your local first responders will see when they don't spend tens of thousands of dollars looking for people who are gone missing with these devices. At its core, this bill is about dignity, independence, and safety. Families should not have to choose between giving their loved ones freedom to live their life and protecting them from life-threatening danger. And access to life-saving technology should never depend on whether a family can afford it. Rashawn ultimately was very fortunate. His story ended with him being found alive. This bill makes sure that more stories will end that way. I respectfully urge a favorable report on 1117. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. You saw me on Tuesday for House Bill 1434, which is one of 5 bills related to the LEAD Act, Layla's Elopement Awareness and Dissemination Act, and this being one of them. So it's a framework around elopement education, preparedness, and response. You know, I just want to put it in perspective. When we have personal property that we don't want to lose, some of us put trackers on it. Your wallet, you know, luggage, you put your name on it in case it gets lost. Well, what about if your child elopes like mine did, who's nonverbal, and luckily we found her? But what happens if she goes into a pond and drowns, which is very likely because she doesn't understand water? What happens if someone finds her and tries to communicate with her and doesn't know who she is? We see it all the time where people are publishing pictures. Do you know this person? So if we take our personal property of value in that manner, why wouldn't we do the same for our children and our adults that live this reality day after day? Delegate Lopez, thank you for bringing this very important bill forward that is saving lives, that will save lives. These trackers are essential, and you'll hear stories here today of why they're essential. These emergency elopement response devices are medical necessities. When you think of a child that has allergic reactions that could be very severe, an EpiPen is close. It's about being prepared and responding to the emergency. Similar to an adult that has diabetes, you have a glucose monitor to make sure the levels are not dangerous. And if they are, you're prepared to respond immediately. These elopement response devices are the same thing. These are life-saving devices that families rely on because elopement will happen. It is inevitable, and our national experts are saying it will happen 49% of the time for children with autism, 60% of the time for adults with dementia. So with that, I urge a favorable report for our friends, our daughters, our sons, our siblings, our parents, and our neighbors. Thank you.
All right, thank you, Chair, Vice Chair, members of the committee. Good evening. I think it's the first time I've had to say good evening while being at this table, so try to keep it short for you. My name's Cody Stevens. I'm from the Eastern Shore. Some of you may already know my story, so I've been here a few times telling my son's story. But he lives with neurological disabilities with a significant risk of elopement. It's not simply just a wandering behavior like we discussed. You know, it's leaving the idea of a safe environment and the ability to recognize the danger and then return to safety. Luke's experienced plenty of moments where he's wandered away from safe environments without understanding the risk around him. There have been times where he's found in places that were truly frightening and stopped just before, or stopped just before entering situations that could have resulted in serious harm. For individuals like Luke with neurological or developmental disabilities, this is one of the most serious safety risk caregivers face. Stepping away from my testimony for a minute, there are many things that we've had to put in place for Luke, for his safety, because of things that he doesn't personally understand. One of which has been the idea of homeschooling him. On top of his different disabilities, he has different things that we help him with at home on top of his education. So working with him is a full-time job. However, we do still have the elopement issue with him. So in times where we could potentially let him grow into himself, make new friends, be part of the community and part of school, we hesitate. House Bill 1117 takes that hesitation away for us. It allows us to explore our options a little bit more. It takes that important step towards addressing risk, but then also addressing his opportunity to grow. This bill ensures that approved elopement response devices, such as wearable location-enabled devices, door-to-door window sensors, alerting technologies, can be recognized as medical devices and assistive technology when covered through the Medical Assistance Program and certain insurance plans. For individuals like Luke, this device is not just a convenience. They are safety tools that can help caregivers respond quickly when seconds matter. And importantly, these tools are far less costly than the consequences of the elopement incident that leads to emergency responses, hospitalizations, or the worst that we can all imagine together without saying. Supporting prevention is both safety and decision and responsible for the use of resources. For these reasons, I respectfully ask for a favorable report on House Bill 1117. Thank you.
Good evening, Chair Bagnall, Vice Chair Cullison, and members of the committee. Thank you for the opportunity to testify today. I am Sarah Westrick, the Advocacy Director for AARP Maryland, here representing our 850,000 members in the state. Thank you to Delegate Lopez for introducing this important legislation. Elopement, also known as wandering, affects thousands of Maryland families each year, especially those caring for individuals with autism, dementia, Alzheimer's disease, and other conditions. The risks are immediate and life-threatening, and families often face these dangers without affordable access to basic technology that could prevent tragedy. House Bill 1117 ensures that elopement response devices such as door and window sensors and wearable GPS-enabled tools are recognized as necessary medical or assistive technology. When prescribed by a qualified provider and included in a care plan, these devices would finally be accessible rather than cost prohibitive. The devices are essential safety tools. Covering them will reduce emergency responses, prevent avoidable hospitalizations, and help individuals remain safely in their homes. An estimated 60% of people with dementia will elope at least once. And Maryland has more than 148,000 residents living with dementia. Each incident not only impacts the individual, but their caregivers, families, and first responders. House Bill 1117 strengthens Maryland's broader LEAD Act framework and offers practical, immediate support for families across the lifespan. By passing this bill, Maryland could lead the nation in creating safer communities for residents at risk of elopement. For these reasons, AARP Maryland respectfully urges a favorable report. Thank you.
Thank you for your testimony. I had a Lindsay Cuthbert on your sponsor panel as well. You want to come forward and give your testimony?
Hello, Madam Chair. Sorry. And committee. My name is Lindsay Cuthbert, and I'm here today as both a para-educator through Harford County Public Schools, working in a school for special needs children, and as the parent of a child with significant autism, nonverbal, and also medication-resistant epilepsy. Starting with from the professional side, of the 137 kids in our school, about 25% of them are confined to wheelchairs, which significantly lowers their ability to elope. That leaves the other 75%, with the exception of maybe 2 of our older kids, that are at risk for eloping, which is around 100 children just in one school. And there are schools like ours all over the state, and there are programs within public schools even more so. The leading cause, or a leading cause, of preventable death for children with autism and children with epilepsy is drowning. I have a 10-year-old daughter who has, like I said, epilepsy and autism. She is definitely prone to eloping, and she's getting big, she's getting smart, and she's getting strong. She is unlocking doors. She will climb out her window if she got a chance. I think she might tuck and roll out of my car if she could, just to go wandering around. She loves the water. She will run towards it if she gets the opportunity, and she cannot recognize danger. That being said, she looks like she's about 12 or 13 years old, so she is not immediately flagged by a stranger as a child who's alone and at risk or in danger. So a passerby might not stop and say, you know, where's this kid's mother, like they might have a few years ago. None of the responsibility of maintaining Bella's care or Layla's care ends at 18 years old. This is a lifespan issue that our children are going to deal with, that we are going to be responsible for the rest of their lives. For these reasons, I respectfully urge a favorable vote for House Bill 1117. Thank you.
Thank you for your testimony. I'm going to open it up to the members for questions. Are there any questions for the sponsor or her panel? Vice Chair Cullison.
Thank you, Madam Chair. So the concern that the insurers have is that there's certainly a medical, the medical condition of the person contributes to this possibility, but the device itself is not medical. So I'm wondering if you have considered or looked into any other programmatic options for, and I'm thinking of our, we have facility that has a lot of equipment for blind people. And right now I'm completely drawing a blank on it. It's in Baltimore City, and I visited there, and there are so many resources that they have there. I'm not saying that's the right place, but I'm wondering if there is a place where a program like this could fit more than insurance.
Thank you, Vice Chair Cullison, if I may answer that. So locally here in Maryland, the challenge has been, if you try to create, if you want to be a vendor for DME, durable medical equipment, wearable technology with regards to like this kind of device is not recognized as a type of technology that's needed. So part of this bill is encouraging that recognition, so that way vendors can be able to support Marylanders with these life-saving devices. From a Medicaid and Medicare perspective, there was some work years ago done through the National Autism Association and other coalitions where a diagnostic code is currently in place for wandering and elopement. However, again, it goes back to these elopement response devices not necessarily being categorized as something that is fitting into that category. But if you do a Google search, there are many of companies that are offering these specific to wandering and elopement. It's just really now recognizing that these are tools that many families are using, and instead of families paying upwards of $1,500 a year for a device, and that's on the low end, why not cover it for these families, or at least cover some of it for these families, because these are life-saving tools. So that's what this bill is presenting, that notion of elopement response devices are important and medically necessary.
Right, thank you.
You're welcome.
Delegate Johnson.
Thank you, Madam Chair, and thank you for the bill. If anyone knows, I know some first alerts are covered by Medicaid. So do they consider those medical devices and not this?
Thank you, Delegate Johnson. Yes, they are considered medical devices, but they're not GPS trackers. Right, so that is the biggest difference, is when you talk about GPS tracking, it's typically you're tracking your car, your wallet, your personal property, not a person. And we're trying to encourage that these are important tools to be able to track individuals. Not putting Rashawn and his family on the spot here, but think 6 days. Can you imagine not being able to find your child for 6 days? And this is a child that can't ask for help either. So when you think about scenarios like that, having a mechanism that could have found Rashawn in seconds, in minutes versus in days. And to Delegate Lopez's point, think of all the resources that were deployed for that search that now would be extremely reduced.
Thank you. Thank you, Madam.
Delegate Riley.
Thank you, Madam Chair. Thank you all for being here, and sorry what you're going through. And for the bill, for Delegate Lopez. I have a question. So in the letter from the Maryland Department of Health, they also showed the expense of this. And they also mentioned, okay, so much for the device, the tracker itself. And then they talk about monthly, ongoing payments, monthly payments. Is it something that you might consider that, okay, maybe the original price of it, if, you can change that it's, medically necessary and life-saving for this person. And then maybe not the payments, go, outward. I don't know. I mean, I personally have gone through 2 tragic, personal for someone eloping and getting killed. So, it is very passionate to me. But maybe, that I'm just saying that might be an idea, so the cost isn't so high that maybe, just maybe the original device. I don't know. But
yeah, I appreciate the question and suggestion, and I would just say, given the hour of things, I'm open and willing to negotiate with the Department of Health and whomever about figuring out a way to make the money make sense, because that should not be ultimately the barrier that keeps people from connecting with their family members in these moments.
Sure. All right, seeing no further questions, We do have one panel of favorables, so thank you very much for your testimony.
Thank you for your time.
And we're going to bring Reginald Lawson to the table and also bring up virtually Taylor Ware and Madeline Ciotola. And Mr. Lawson, you can get started with your testimony when you're ready.
Good evening, Madam Chair, committee members. It's good to see you again. My name is Reginald A. Lawson, and I'm here to support House Bill 1117. I'm a former caregiver of my mother, who at the time lived 2 hours away from me. I tried with little success to engage others to help watch her, and removing her from her home presented emotional, financial, and physical challenges. I learned quickly and painfully it was going to take more than prayers, good intentions, and luck to protect her. I needed to facilitate tangible means to understand and reduce dementia's threats. During my 4-year caregiving journey, I employed technology where I could. This included cameras, speakers, motion detectors, automated systems that would turn water and gas on and off because dementia took away her sense of risk. Excuse me. Now, that worked as long as she stayed in the house, but as soon as she went out, then she was more vulnerable. At that time, I employed GPS-infused sneakers. That was in 2012. Here are some of the benefits of having supportive devices. One, it allowed me to constantly monitor her activities as well as her rest periods. It also provided insights regarding her range of movement in and outside the house. It helped me to better analyze and understand her elopement patterns. And most importantly, it controlled my anxiety by reducing her exposure to danger. At the time, I could afford $300 sneakers and $7,000 worth of equipment to monitor her. However, most people may not have the financial means to afford a responsive device. Please understand that elopement dangers are the same regardless of a person's financial capabilities. House Bill 117 will enhance stakeholders' abilities to afford and leverage these life-saving devices. I respectfully ask this committee to be our partners on this journey by issuing a favorable report for House Bill 117. Thank you.
Thank you for your testimony. Let the record reflect, Taylor Ware is not in the waiting room. So Madeline Ciotola, if you want to go ahead and unmute and give us your testimony.
Good afternoon. Can you guys hear me okay?
Yes, we can.
Okay. Good afternoon, Chair Bagnall and Vice Chair Collison and members of the committee. My name is Maddie Ciotola, and I am the mom of Lincoln, a 4-year-old boy living with Angelman syndrome. Angelman syndrome means that Lincoln will likely remain nonverbal throughout his life, and he will live with an intellectual disability. If you Google Angelman syndrome online, one of the first characteristics you will see is a fascination with water. That is certainly true for Lincoln and for many of the other angels that I have met. When you combine an intellectual disability, the inability to call for help, and a love of water, safety becomes a constant concern. At home, we've done everything we can to protect Lincoln. We have multiple gates, doorknob covers, sensors on our doors, and more. But even with all of those safeguards, just a few months ago while I was making dinner, Lincoln quietly figured out how to unlock one of our gates for the first time, walked down the stairs, and out our front door. The stove was on and water was running, and I didn't hear a thing. Luckily, our doorbell camera sent a loud motion alert to my phone. Without that alert, it could have been minutes before I realized he was gone. And in situations like this, every minute matters. This experience made something very clear to me. If this can happen in my own home, it can happen anywhere. Sending Lincoln to school, which we do, putting him on a bus, trusting that someone won't accidentally let him off at the wrong stop, these are worries that live in the minds of caregivers every single day. To help ease that fear, we purchased a GPS tracking device that we attach to Lincoln's clothing each morning, and it allows us to quickly locate him if he ever wanders. We are fortunate. We have stable jobs and a strong support system, but these devices often require costly upfront purchase. Ours, for example, was $225, followed by a monthly subscription ranging from $45 to $65 a month. Many families facing significant medical and caregiving expenses, that cost can be out of reach. But the peace of mind these devices provide and the lives they can help protect is invaluable. Coverage for life-saving location devices would give families like mine one more tool to keep our loved ones safe. Legislation like House Bill 1117 helps families access life-saving devices for their kids while creating safer environments for students who may require additional protections due to disability or cognitive differences. I respectfully urge the committee to issue a favorable report on House Bill 1117. Thank you.
Thank you for your testimony. Are there any questions for this panel from the members? Seeing none, thank you very much for your testimony today. This concludes the bill hearing on House Bill 1117 and concludes our bill hearings for today.